Y O N E two one zero 515. Oh, may I finish?
Hmm. Good morning, everyone. Can I do it? Hello, good morning, everyone. Hmm?
Good morning, sir.
Okay. How are we all? We are battling, we've been battling with the network, but we are able to connect now. Let me share the slides. Are you from the first slide? Okay. Thank you once again for having time to be with us. In all this presentation, I have a summary. We have up to around 98 slides, and I wish to divide the presentation into two. Um, the first part of the presentation will be I will be having like 49 slides or 48. That is exactly like half of the slides. Then we'll go for a break. Then we'll come back and finish the remaining 49 slides. I think that should be fair, cool. Therefore, the topic of today's presentation, do the title is Erb's palsy, is it? Yes, but actually it does not make meaning to discuss only Erb's palsy. Uh, Therefore, as a whole, we want to discuss pediatric brachial plexus injury, and hope we are all listening because
Yes,
network.
sir, we're listening.
Are we? Okay, thank you.
Yes, yes, we are listening.
Therefore, we are discussing brachial plexus injury and the classifications. Then we now tailor our discussion to what do you call it? Erb's palsy, and then we discuss. Going to start discussing assessments of the infants. Then later we come to discussing assessments of the older children. Then Probably we now discuss physiotherapy techniques of assessments and management procedures, then the evidences based on systematic review, and then we have handling procedures based on one pediatric group of chartered physiotherapists. I was able to get a lot of information on that one, at least for presentation. At times, the therapist may use that to give as home-based exercise for the parents. That is very important. Therefore, I remain yours. My name is Dr. Umar Muhammad Badaru, and we start by introducing pediatric brachial plexus injury. That it has so many synonyms. We'll go to the internet, we see perinatal brachial plexus palsy, we see obstetric brachial plexus palsy, we see brachial plexus bat injury, we see obstetric brachial plexus palsy. Please, there are so many synonyms that are being used in so many places. Therefore, when we hear this name, we are not restricted to only Erb's palsy or Comcast palsy or Erb's palsy. No, it is the name that signifies um, impairment of the normal functioning of our brachial plexus. And then they say generally brachial plexus injury occur during the birth process. Therefore, when we are discussing pediatric brachial plexus injury, that is why other people call it perinatal, because usually whatever happens to it usually is through the process of giving birth. Therefore, it occurs primarily during the process of giving birth, but in other children, it may occur due to other issues. It may be traumatic, then it may be tumor, it may be any other thing that can cause brachial plexus injury, but too much restrict to this. Okay. It is defined as one means is that you have a child of the two limbs, he has upper limbs, the affected limb, there is paucity of movement. For all forms of movement probably may have to be done by the mother because the child hardly use the other hand, but the other hand they then find it. And then in the next slide, we are seeing our brachial plexus injury. And then the root starts from C5. Therefore, we have C5, C6, we have C7, and we have C8 and T1. And then you have to revise our anatomy of how each of the roots form the trunk, how each of the trunk now divide and form the cords. And then from the cords, we have all the nerves supplying the upper limb. Then the next is the incidence of brachial plexus injury, pediatric brachial plexus injury. We have seen there are so many heterogeneous findings on this. There's no single finding on the real incidence or prevalence. The issue is I now take the ones that are much more closer. One says it's between 0.38 to 4.6 per thousand live birth, meaning that out of at least every, and then another study has reported up to 1 per thousand live birth, meaning that in every 1,000 babies that are being given birth to, and then the etiology of pediatric brachial plexus injury is shoulder dystocia. This dystocia means the shoulder actually gets stuck within the pelvis of the slideshow. They are not seeing. Okay, are they seeing now? Is it okay?
Better now.
Shoulder dystocia, where the shoulder gets stuck. Okay, where the shoulder gets stuck, and it's the baby refuses to come out by pulling the neck. Therefore, they call this dystocia. They define as a unilateral traction injury due to catching of the anterior or posterior shoulder behind the shoulder, which is a predisposing factor. Therefore, the woman is probably the prolonged labor may be as a result of post delivery where they pull the child, and then we have with a 4.5 to 5 kg. The post okay, uh, we are back. We had a little network hitch or glitch. Then the next we are going to look at, okay, we have to look at the etiology or what we call the risk factors. Then we now there are three forms of brachial plexus injury that is acceptable worldwide, but are forms of classification. The first one as Erb's palsy, Columbus palsy, and Erb's Columbus palsy. Erb's palsy at T1 and Erb's Columbus palsy is between C5 and T1. But therefore, remember have Erb's palsy T1 have Horner syndrome. Then the Erb's Columbus palsy, total paralysis of the upper limb. Then we now is classification by some other people again. They said we have upper brachial plexus lesion. That's uh, abducens palsy and C7 lesion, meaning that it's associated with Horner syndrome. We have ptosis, we have we have what do you call it? We have uh, the Naraka's classification. The Naraka's classification, what they mean here is Naraka actually modified this our classification. Is that this disease is hardly clump palsy. It is either somebody is having C7, one clump palsy. They said hardly. Wow, the new Naraka's classification is almost what do you call it, missing, because it's not usually, it is the prevalence is very small. Then we now have the classification by Narakas. This is the Narakas. Which one? Spreadsheet. Yes, flash. Hmm? Okay, here we have, if we can all see, um, when the brachial plexus, we have upper F palsy, C5, C6 are affected. Am I still sharing? Okay. The next is 2A. We have extended F palsy with early recovery of wrist extension, C5, C6, and some part of C7. And then the paralysis involves wrist drop. Look at the likely outcome, with spontaneous recovery in greater than 60% of cases. Therefore, where you have some part of C7 affected, majorly C5, C6, the recovery is also good. More than 50%, 60% are having spontaneous recovery. Then we now have extended F palsy 2. We have C5, C6, but now more involvement of C7. Here they said, as above, there is also wrist drop, and they said good spontaneous recovery in more than 60% of cases, like this one. Then we now have global palsy with Horner syndrome. Now here we mean there is serious affectation between C5 to C8 and T1, meaning that it's total brachial plexus injury. Remember, we have said it. Clumpius palsy between C8 and T1 these days they say is rare. Therefore, that is why they come with this revised classification. Therefore, they are now have, instead of having what do you call it? We don't have C8 T1 isolated now. We only have C5 up to C8 and T1, I mean total brachial plexus injury. And then here they said good spontaneous recovery of shoulder, 30 to 50% of cases. Functional hand, what do you call it? Functional hand frequently noted. But there is something we should understand here. Where you have global affectation, it's less likely you have recovery in up to 50% of cases. In more than 50% of cases, they require surgery. Then we now have 5. This is the list. We have global palsy with Horner syndrome. Then we have complete flaccid paralysis with Horner syndrome. Without surgery, severe arm deficits are expected. But what we are really saying is wherever you have C5 to T1 involvement, definitely the prognosis will not be very good. Spontaneous recovery is likely going to be more than 50% in most of the cases. Therefore, they need, what do you call it? They need, okay, somebody raise hand. Hello?
Yes, sir. I have a question concerning the 2A, sir.
Okay.
You mentioned extended Erb's palsy with early recovery of the wrist extension. So I want to ask, how early is the early recovery, sir? Like,
Yes,
what's the time frame?
yes, usually early recovery is within the span of 8 weeks. When we really go inside, we now see that early recovery, it shouldn't be more than 8 weeks. If some recovery did not occur based on the rating of some scale, like AMS scale and Toronto scale, there are some parameters they use. If you couldn't get those recovery, it's better you send the patient back to the doctors for further assessment and probably surgery. Meaning that we are dealing with infants. First, we receive infants as physiotherapists. Therefore, we begin to manage them. By 8 weeks, if we do not observe the amount of recovery that is required, then based on those scales which we are going to discuss, then we should refer them back for possible further assessment and possible surgery. What we are dealing with is something that we can get results in 8 weeks. That is what they are saying.
Thank you, sir.
Okay, thank you. Okay, the next is okay, then we are going to look at Dejerine Colombkes palsy. I refuse to start with Erb's palsy because Erb's palsy is the topic of our discussion today. Therefore, it will come at the last end so that I just discuss continuously on it. We have the Dejerine, what do you call it, Colombkes palsy. It is named after Augusta Dejerine Colombke, and it's a neuropathy involving the lower brachial plexus injury C81. And they said it causes weakness and atrophy of intrinsic muscles of the hand, resulting in clue hand. Erb's palsy, everybody knows what we call the waiter C position, policeman hand. But in this guy, the most notable, what do you call it, deformity is the claw hand. And then, in our anatomy, we know when there is, what do you call it, there is injury to the ulnar nerve, some people develop claw hand. But this one, in Colombkes palsy, it presents with also claw hand. And then actually what differentiates mostly the Erb's palsy and Colombkes palsy is the grasp. Children with Erb's palsy have good grasp reflex, but children with what do you call it, Colombkes palsy have no grasp reflex. Children with Erb's palsy lack supination, while children with Colombkes palsy lack pronation. Therefore, it's like somehow the cause is hyperadduction and traction of the arm. The child refuses to come out. Some people just pull one of the shoulders that just come out with force. Therefore, that is hyperadduction and what pulling of the hand. That is what causes this. Now, these days they say it's hardly. Do you see this one? That is why the revised classification is like they almost in a way remove Colombkes palsy. Then clinical sometimes weakness of long flexors of the finger. Yes, and that is what contributes to lack of grasp reflex, and the rarely weakness of the wrist flexors. Then we now have triceps breaker usually remains intact. But yes, meaning that there can be variable presentation in this place. It's like opposite of Erb's palsy. In Erb's palsy, the triceps is strong. Only the biceps is weak because the elbow is in extension. But in this guy, the triceps may be okay. In some individuals, the tricep may also be affected. Meaning that while in Erb's palsy, the triceps is strong and the biceps is weak. In Columbus palsy, the triceps may be intact or may be affected. Then we now have Horner syndrome, which what do you call it? Is the impairment of swelling. It's a lateral ptosis. Ptosis meaning inability to raise one of the eyebrow on the same side. When C7 is affected and there is what do you call it? They call one stellate ganglion is also affected. What happens is the child will not be able to open the upper eyelid, just like somebody who is having facial palsy. Weakness of levator palpebrae superioris. What happens is may not be able to this. Then we now have meiosis. That's what do you call it? We are going to discuss it later. The etiology, the most common etiology in the Columbus palsy is hyperabduction trauma to the arm, pulling. Then we can still have another cases in older children. It mimics what do you call it, Columbus palsy, or it can present with similar presentation like that of Columbus palsy. They said is when you have a long tumor uh, where it gets to a size where it presses on the cervical what do you call it, ganglia or CAT1 nerve root. It occurs in children that have associated. Okay, therefore, here instead of having weakness of forearm, like in F palsy, I told you we have weakness of forearm supinatus. The child cannot open the hand, but here is a weakness of pronatus. What you call wrist and finger flexors are also weak. Therefore, the hand does not have what? There is no hand function. Therefore, we say C7 involvement results in Horner syndrome, and then the sensory deficit is on the ulnar side of the hand. It's on the ulnar side of the, meaning that the inner side of the hand towards the small finger. Therefore, I think we have a little picture, a diagram. Let me see the diagram. Yes, this is the diagram. Sensory deficit in Columbus palsy. The sensory deficit, you can look at the elbow side. The sensory deficit, you can look at the small and middle, what do you call it? The small and what do you call it? What is this finger very close to the small one? And the finger close to it. The ring finger, actually. The ring finger, yes. Usually there is loss of sensation around that side, and that is the ulnar side. Then the prevalence of Columbus palsy. Now, this is what do you call it, Narakas look at, and they come with the revised classification. They say the Columbus is most uncommon in modern obstetric practice, meaning that it's not very, very common. Now, it accounts for only 0.6%, meaning that in 1,000, hardly will you see anyone. Therefore, that is with the Columbus palsy. Therefore, what happened now is we are likely going to see either F palsy or total brachial plexus injury. Okay, this is okay. Then we now have F palsy. In F palsy, they mean total brachial plexus injury. This one is C5, C6, this one C7, C8, and T1, meaning that nerve roots from C5 to T1, as we see in the diagram, they are all affected. Is a total brachial plexus injury. The clinical presentation is total extremity paralysis, meaning that they are talking about stage 5 of the Narakas. The sensory deficit in distribution of the entire hand, C5 to T1. Okay, here we have the sign and symptoms that are indicative of extensive nerve injury. The presence of Horner syndrome, ptosis, drooping of the upper eyelid, meiosis, pupil constriction, and anhidrosis, dry eye. Therefore, they believe if you see this one, there is extensive damage. Remember, we said in one of the classification, we have what you call, they divide it into 3. They have upper brachial plexus. Then they have clunkius palsy, and they have C7 palsy. That is another classification. This C7 palsy is telling you that once C7 is affected, you are likely going to have stellate ganglion damage. You are likely going to have Horner syndrome, and they say it's indicative of extensive nerve injury. Then they said asymmetric chest expansion are symptoms of partial denervation of the diaphragm. Therefore, remember, the diaphragm has root from C3 to C5. There may be some extensive injuries that may start from C4, because in our anatomy, when you see C3 through C5, at times you see one of the roots being highlighted, bolded, meaning that is the main root. If C4 is involved in the process, then the diaphragm is likely going to become affected. Then that one has become an emergency. Then we now have what we call the medical red flags. These are the red flags you see in children with in brachial plexus injury, that requires that we should we should we should refer the patients to for further medical assessment. We have decreased thoracic movement, unilateral diaphragmatic elevation, respiratory distress, cyanosis, the limbs becoming bluish, asymmetric chest movement during expiration, and frequent lung infections. You are managing the mother telling that the child is actually having asthma. This you just begin to think probably frequent colds. Ask them to do checks, X-ray. Probably there is likelihood the child is having labored breathing and weakness of the diaphragm. They say management, we should stop treatment and seek medical attention straight. Okay, now we have introduced Erb's palsy. We have introduced Clomke's palsy and Clomke's palsy. That is a total, brachial plexus injury. The next, which is the main presentation of today, we really deem it fit to introduce the other two. Then that is the Erb's palsy, which is the injury to the upper trunk of the brachial plexus, C5, C6. And then it affects majorly the deltoid, the biceps, the brachioradialis, and supinator muscles, majorly. But there are other muscles of the hand, most especially the wrist extensors, are also affected. Then they said infants present with Wetter's tip sign, with the arm adducted and internally rotated. The Wetter's tip sign is what we call policeman hand or Wetter's tip position. It's better we say relay man hand, because when we observe sportsmen doing relay, when they want to collect baton, the hand will just be turned behind. That's like somebody want to collect baton in a relay. Yes, that is the Wetter's tip sign. Then we have two pictures here. One is a real picture of a baby having Erb's palsy. By the observation, this is part of what we really need as physiotherapists to do, spontaneous movement. By spontaneous movement, you see the baby raising one of the hand, but the other hand is not moving. Definitely by seeing this, you know there is positive movement in one of the hand, which is almost similar to what you have on the picture. Then sensory deficit is not always present in Erb's palsy. And they said, but if there is one, it's located on the shoulder, the lateral surface of the upper arm, and the radial edge of the arm, meaning that it crosses just across the hand, just like we have the way we used to have our spiral fracture. This one, it just spiral across the hand. We are going to see it. This is how it is. Therefore, it's like it's going to cross across the hand from the shoulder to the lateral upper part of the, of the elbow joint. Remember, we used to put our stethoscope on the medial side. There will be loss of sensation on the lateral side of it. Then it will now cross towards the medial side of the hand. That is where the sensation. But definitely, they said sensation is usually not lost. Sensation is usually not lost. But if it is lost, then it should be around the deltoid, upper lateral part of the elbow joint, then crossing to the medial part of the forearm and hand. Then we now have clinical presentation. Yes, usually we used to say 5 deformities in Erb's palsy. The 5 deformities in Erb's palsy, they said is shoulder adduction, that is 1, internal rotation 2, then elbow extension, lack of, that means there is lack of flexion. 3, forearm pronation. 4, wrist and finger flexion. 5. Those are the 5 deformities in Erb's palsy. But remember, in Klumpke's palsy, instead of having forearm pronation, they have forearm supination because the pronators are weak. Then they say scapular winging may occur. Therefore, long thoracic nerve is likely going to be affected. Grasp is intact. And then remember, we said grasp as a physiotherapist is what differentiates between Erb's and Klumpke's palsy. Despite the fact that this one presents with waiter still position, the other one presents with claw hand. But when you check for grasp reflex and it's intact, Erb's palsy is the one. When you check grasp reflex is entirely totally missing, then it's likely going to be Klumpke's palsy or Erb's Klumpke's palsy, the total paralysis. Okay, the overall incidence of Erb's palsy is 1.74 per thousand, meaning that there is around 2 per thousand. Therefore, in every 1,000 live birth, you are likely going to see 2. That is why they say it's much more common than any other one. They say the etiology is always tearing force caused by traction to the head. The risk factors include, therefore, the risk factor for brachial plexus injury is the same thing as the risk factor for what? Erb's palsy. Yes, they don't have other risk factors other than this one. Then they say shoulder dystocia, meaning that the shoulder becoming stuck until something is done. Macrosomia when the child is big. Maternal diabetes is a predisposing factor from macrosomia. Instrumental delivery when you use a vacuum pump to pull the baby. Then breech delivery when the child refuses to come. Cephalic using the head. It comes with the leg. At times, one of the hand will come out and somebody will pull the hand. Prevention is difficult owing to the unpredictability and open labor related risks. But one thing is, based on research, they found that at least cesarean section is one of the ways of preventing Erb's palsy. Therefore, women that opted for elective surgery are likely going to have children with Erb's palsy. Though they have said some children with Erb's palsy come with it even when the mother has it, and they begin to look for reasons why children have Erb's palsy, despite the fact that the mother underwent cesarean section. Probably they would one day find reason for those ones. Then pathophysiology. Here we are likely going to look at the severity of the Erb's palsy. Despite the fact that we said Erb's palsy is much more has better prospect of recovery than other the two other ones, the Klumpke's and the Erb's Klumpke's. That is the total brachial plexus involvement. But even with Erb's palsy, it depends on the severity. If it is neuropraxia, then it's less severe and it heals without any complication. Then we now have the axonotomesis. This involves destruction of the axon and myelin sheaths, and then it may take months to heal, even with proper treatment. Therefore, it does not occur spontaneously. Therefore, where the axon and the myelin that have it, but remember, the axon and the myelin remain intact. Then we have the worst prognosis is the neurotomesis, where you have avulsion, that is the detachment of the roots. This affects the axon, the myelin sheaths, and the supporting structures to the nerves. With that one, immediately one is able to get that one is the good candidate for reconstructive surgery. Here we have degree of nerve injury explained in this picture. The last one here, the one below, is neuropraxia. The nerve is intact, only pulling, but the axon and the the myelin sheaths are intact. Therefore, it recovers. Then the other one, you can see the dash is telling you that the axon is disrupted, but the myelin is what? Intact. The other one, both the axon and the myelin are what? Cut. And there is never going to be recovery until a surgery is conducted on this hand. Therefore, at times, the child will lose sensation, will lose everything, no movement. For several months, we keep managing. And a physiotherapist would think that actually it's his own technique that is not working, not knowing that the degree of nerve damage is actually what is preventing good recovery. Definitely, there must be synergy between the physiotherapist and the referring pediatrician, such that they will know what to do if the child is not actually recovering. Then physical examination. Yes, physical therapy or physiotherapy examination. Here we obtain prenatal birth and infant history. This is very, very important. The mother will tell you everything, all the events that occur during the delivery. Then probably in the next slides, we are going to see weight is also going to be important. We have to know the weight of the baby. They make a lot of sense when we are documenting the cases of what they call brachial injury. Then we have paralysis may cause decreased growth in the affected site. Therefore, like for babies that did not appear on time, it's very, very common in this environment. I have managed a patient in a private setting where the doctor asked him to be raising the hand and not come for physiotherapy on time. By the time they came, they were so apprehensive that we should explain to them what we are going to do. Then when I observe the hand, I look at the contour of the two shoulders. I look at the hand, I realize that one, the affected upper limb has started atrophying. Therefore, there may be decreased growth, there may be atrophy in the affected hand. We should examine that one vis-a-vis the time they started coming for physiotherapy. Even the window period for spontaneous recovery after 2 months, it's already gone. Then you now come for physiotherapy, what are you really going to get? They say we look for obvious deformity, like waiter's position is a good sign. Therefore, at times you don't need to even say, how do I differentiate between clump case and Erb's palsy? After all, you have seen waiter's position, policeman hand, obviously you don't have to do anything. Okay, we are still reminding ourselves in this picture, this is the waiter's position. We instead of saying policeman hand, we say relayman's hand. Okay, then we are revising again the motor deficit in Erb's palsy for shoulder abduction. Okay, you can see in this picture where you have area of weakness, meaning that if there is weakness in shoulder abduction, the hand will be adducted. Remember, we said that is one of the deformity. Where we have shoulder external rotation is mainly by C5, and then it is done by supra and infraspinatus muscle. Then we have to, meaning that the resulting position will now become internal rotation instead of what the shoulder to be at neutral or external rotation. Elbow flexion is done by C5, C6, which is biceps, brachii, and brachialis. Remember the biceps muscles are three: brachialis, coracobrachialis, and bicep brachii. Therefore, here C5, C6, they mention only two: biceps, brachii, and brachioradialis. Then the hand will remain extended instead of the child being able to flex. Therefore, this is the picture. We don't have to repeat again, but it's important. Why I brought this picture is that with physiotherapy, so when we are stimulating, we should know that it's just like reminding ourselves of the anatomy we know. Elbow flexion is being by this, elbow extension by this, all these things is very, very important. The next, we now, yes, actually I divided the assessment into two majorly: assessment of the infant and assessment of older children. Therefore, we are going to start with the assessment of the infant. Then later when we come after break, we are going to continue with the assessment of the older children. Okay. We said one should observe for signs of respiratory compromise, suggesting phrenic nerve injury. We have said it, meaning that this is very, very important for physiotherapists. Immediately, most especially for those that came. Okay, I can see a participant raising hand. Mariam, you're welcome, please. Ask your question.
Good morning, sir.
Good morning.
So my question is about one patient that I'm treating, sir.
Okay.
Initially, the patient presented to us with a typical sign of Erb's palsy. Later on, as we are treating the patient now suddenly start to develop a claw hand, and we check for and we check for signs of Horner signs. There is no any sign for that. So actually,
yes, it may see Horner sign may occur in conjunction with what do you call it, Columbus palsy, and it may not occur. It depends on the affectation of C7. You know, for Columbus palsy is C81. That is the lower root. But at times C7 is affected. If C7 is affected, then you see Horner sign. Okay, continue.
So actually, the case is actually confusing us. Now we're just trying to manage to stimulate the intrinsic muscles of the hand to see that whether it can work for the patient. So I don't know whether we are on the right track or.
Yes, usually
I
in
don't.
this case, it's likely you are having epicolombus palsy. It's very likely
Okay.
you are
Oh,
having epicolombus palsy, affectation of both C5, C6, C7, C8, T1, but without Horner syndrome. And that is the
yes.
classification by Naraka's stage 4, not 5.
Okay. So we cannot call it a
Yes,
clunkers palsy that one.
no, it's Epps-Clomkes palsy. It's likely Epps-Clomkes palsy, but without
Okay.
Horner syndrome.
Without Sona syndrome, yes. Okay,
Yeah,
thank
without
you, sir.
Horner syndrome. And then
Okay.
they are the guys that would not up to 50% will reach full recovery. At times,
Okay.
it may require further assessment again. If you have pediatric neurologists, they may look at the possibility of trying to say, okay, let's see if we can do some tests. They can go for MRI and this and see the extent of the injury. Because at times they refer the patient to us, but without doing what do you call it, extensive assessment of the nerve involvement. It is
Mm,
after we see that we are not really getting results, we refer them back or we do some clinical talk with them. Then they will now say, okay, let them do MRI or CT, and they will now see the the extent of the injury. Probably surgery can be done.
okay. So now for
Okay,
this patient, the best thing is just for us to refer her back.
yeah, no, you have discussion. At times it's good to have discussion
Okay.
with the pediatrician, and then this is what we are saying. I will want to know the extent of the injury. Can they do some what do you call it, further test? Then, if actually you are not getting any result, this is part 8 week based on the guidelines now. Is for you to refer because it's a good candidate for probably reconstructive surgery.
Okay. The baby is actually up to 9 months, and we started treating this baby since when she's around 3 weeks.
Then what is the program? What is the what do you call it? The
The
improvement that you
shoulder,
recorded.
the shoulder and elbow, there is improvement. But for the
Okay.
hand, she developed claw hand.
Like is what do you call it, club case palsy, more of club
Oh,
case palsy.
okay. But there are no Horner syndrome signs.
There are no Horner syndrome signs.
Okay, okay.
Ideally,
So thank you, sir.
literature is very specific on that one. The Horner syndrome,
Mm,
the Horner syndrome may occur or may not occur as a result of this. But when you see Horner syndrome, it's another sign of what do you call it? What do you call it? C7 damage.
clunk.
Okay,
Yes.
Abosede.
Thank you, sir.
Yes,
Thank you.
yes, sir. I wanted to ask a question about the reconstructive surgery you mentioned earlier. So,
Yes.
when a patient presents, are there clinical signs to know if it is a neurapraxia or if it's actinotomesis or neurotmesis? Because there is a baby we've been managing from, I think, a week old, and the baby is about 4 months now. She presented with Erb's palsy, but the wrist drop is still very much present, even at 4 months now. So I want to ask that, is there a way, once they come in, is there a way we can identify if this is neurapraxia, we are going to get early recovery, or if it's actinotomesis or neurotmesis, so we know when to refer them for the reconstructive surgery? And I want to ask, concerning the reconstructive surgery, what's the earliest time that we can refer them and then they will get like the full benefit of the reconstructive surgery, and how effective is it, the
Yes,
ones that
actually,
do
for the
reconstructive and the one that
yes,
don't do reconstructive?
yes, actually, based on the literature, as I have said before, they said after 8 weeks of intensive physiotherapy, because they said we should see them at least twice or three times in a day. Twice or three times, minimum of three
They come
times in a
every
day.
day to our place, sir.
Yes, therefore, and they said if for 8 weeks we are unable to get anything, meaning that it's not neuropraxia. Remember, we
Okay,
are
sir.
discussing axonotmesis, we say it can last for months.
Yes, sir.
Therefore, if by 8 weeks you
Okay.
are unable to get, but remember there are some what do you call it? When we come to the assessments, we are going to see. Therefore,
Okay.
it is a global assessment. They did not actually isolate some what do you call it, muscle actions, like let's say wrist extension or supination. It's like a global assessment. They will say, okay, if the child does not have to up to so score, meaning that the score did not isolate shoulder movement or did not isolate wrist movement.
Okay.
In some like AMS, probably they will say, okay, shoulder movement. Therefore, in a way, when we reach that place, we now discuss further.
Okay, thank you, sir.
Okay, thank you. Okay, they said, then we continue. We now say the upper extremities are inspected for asymmetry in size, temperature, position, and posture. Yes, the two hands should be assessed. At times, the mother will tell you that actually, when the child was giving birth to, and then they will now come to you after, let's say, 5, 6, 7 weeks. They must have gone elsewhere, or they have started traditional something. Before you know it, atrophy must have started setting in. Then it may still be neuropraxia, probably but poorly managed. The therapist will now see some evidence of recovery have started, then we can take it up from that place. We have to detect the presence of fractures and of the clavicles, of the humerus, of the ribs, or shoulder dislocation is very important, meaning that the therapist can also, based on little assessment of the baby, you can suspect whether there is clavicular fracture. If there is clavicular fracture, then we have to suspend our own movements, or probably until after some few days, so as for the clavicle to heal. Yes. Therefore, if there is ribs involvement, that is why at times we have to look at the movement of the chest. At times the diaphragm may not be affected, but the ribs may have what do you call it? A pain may be emanating from the ribs and that prevents the child from taking deep breath. It may be shoulder dislocation as a result of that pulling. You may also be able to see that one. If one is able to spot this one, then we refer. Despite the fact that we want to do physiotherapy on time, but we now still have to refer. At times, you may see some swelling under the ribs. At times, the child will begin to cry when you palpate the rib side. Then it's very, very important because so many things can happen during the delivery, most especially when the delivery becomes a bit difficult. Then assessment of the infant continue. We said we have to assess the range of motion of all the joints, of the shoulder, of the elbow, of the wrist and fingers. They are very, very important. Observation for spontaneous motor activity. This is very important. We said it. Immediately observe one hand is active, the other one is not active. At times, we as physiotherapists, we do what do you call it? Sensory stimulation. At times, you can use your finger to stimulate a group of muscles. At times, the baby will move. You now see, okay, these muscles are also not affected. Then head and neck should be examined for Horner syndrome. We have said it. Assess for presence of torticollis. Yes, at times the child, due to some injury, most especially to sternocleidomastoid on one side, the child may turn towards the same side and may not want to extend the neck to the other side because it's painful. If care is not taken, the child is going to develop torticollis. If care is not taken, therefore, if there is injury to sternocleidomastoid and the child does not want to move away because of the stretching of the sternocleidomastoid, you now observe and see what you can do. Then we now, after what do you call it? After assessment, we now, okay, please, this slide supposed to come before that other one. I think in the arrangement we have in the history. Remember, we said we are the mother is the physiotherapy is going to gather history, prenatal history, antenatal and postnatal history. Here is part of the history of maternal gestational diabetes, length of maternal labor, mechanical assistance, incidence of hypoxia, infant birth weight. They are part of the history that we left. Okay. Then the next is what you call object or observation. What are you going to observe? They said the infant state. What is this infant state? How the infants look like? How the infants interact with the mother? How irritable is the infant? Is the mother fearful of touching the arm? That tells you that whenever they touch the hand in their home, the child does not sleep. They give them sleepless night. That may influence testing priority. You now begin to think, what is happening? It is uncommon of Erb's palsy to see serious painful hand. There is tendency, there is what do you call it, injury to neck musculature. There is tendency, there is shoulder, what do you call it, dislocation. There is tendency of anything could happen, sternocleidomastoid injury. Therefore, probably, therefore, if the child is irritable, crying unconsolably, then something is wrong. Then you may have to assess for pain and all these guys. That is why they said it may influence your testing priority. Then you have to, what do you call it, observe resting posture. We have said it several times, spontaneous movement, in the neonatal period. Therefore, you cannot tell the baby, move your hand, but you now observe some movements in the baby. Probably when you stimulate, you now see some movement, or spontaneously the child moves the other hand, does not move this one. What is the form of movement? Then some infant maintain head turn away from the affected side, may be indicative of injury to neck musculature. It is possible. Therefore, but the most important thing, wherever the child looks at, the most important thing is it is uncommon for F palsy to see the child only looking at one side. Does not want to turn the head to the other side. That means something is wrong with the neck and the musculature. Then we should be able to, it gives us clue that there is injury probably around the neck musculature. Objective assessment continue. We have to assess the muscle tone in the child. Usually, is it flaccid? At times, primitive reflexes. We are going to look at motor reflex in children, in infants. One of the hand will respond to motor, the other hand will be down. Spontaneous movement, we have said it. Sensation is very, very important, which we are going to look at. Then deep tendon reflexes, and then pain. Then we now have motor reflex absent in the affected arm. Therefore, this is very important. Motor reflex is absent in the affected arm, meaning that if you do motor, the child is going to raise the two legs and one arm and then come for embrace, but the other arm will not move. Then grasp reflex differentiate it from other brachial nerve palsies. Therefore, for child with brachial with F palsy, is likely going to have intact grasp reflex, grasp reflex, but for that with clump case paralysis will now have lost, and those F clump case palsy they all lost grasp reflex. Then for sensory assessment, we are going to assess sensation, pain, proprioception, and neuropathic pain. But actually, it's not going to be easy to assess neuropathic pain in the infant. But we assess for proprioception, though also not very, very easy. For older children, you can assess proprioception, and you can use some scale to assess neuropathic pain. But tactile sensation and pain, we have it's easy to assess in the infant. Okay, then pain assessments, you can use two scales. We have the FLAC scale, and we have the Faces Wong-Baker Faces pain rating scale. Then we have for FLAC, this is used for infants. Actually, it is created for infants, just like the way we have the APGAR score, it is created for infants. The first legs activity, cry, and consolability scale. Then we have the scoring. Remember, we said the scoring is between 0 and 10. That is the maximum, and we assess the behavior. We get clue from the child in 5 categories. If each category is tested from 0 to 2, 2 times 5 will give us 10, meaning that the scoring is from 0 to 10. We score them from 0 to 10 based on pain. Therefore, the higher the score, the more the pain the child has. Like, for example, like you can see no particular expression, or the child is smiling, you give 0, no pain. But if you go to score 2, frequently in constant quivering, clenched jaw, meaning that the child is doing as if it want to grind something, then it's likely the child is in pain. Then normal position of the leg, look at it in score 2, kicking or legs down and up, meaning that it's telling you something is wrong. Then we have activity. The child is X, meaning that the child X the back, or the child is rigid. The limbs are held in rigid position. Probably the child is preventing you from touching. Then you now give score 2. Then crying steadily, like in the score of 2. Subsequently complaints. Therefore, meaning that when the child is crying uncontrollably, then he has a score of 2. Therefore, consolability. Whatever the mother does, if the child does not become consoled, giving him breast milk, trying to play, and the child, that means the child is in serious pain. That is the FLAC scale. Then sensation continues, and we have we can have passive range of motion or tactile sensation. I use to screen for sensation in the upper limb. Yes, for us, usually you can do tactile sensations, tactile stimulation. You now see whether the child feels it. The child may not tell you that, okay, this is what do you call it, deep, what do you call it, stroking. This is just touching. This is light touching. But with tactile sensation, at times you see movements. You now observe that probably the child is feeling it. Then range of motion, that is passive range of motion. As you are doing passive range of motion, you may get some information on likely that the child is having some sensation. This is not actually an objective measure, but one thing is, as physiotherapists today and tomorrow, you are managing children. At times, when you are even a kind of massaging, you now observe that this child is really having some sensation in this limb, but it's not very, very objective. Then behavioral response to dull pinprick or light pinch is tested. Yes, at times you may use some brush. You brush fast, and you see at times you may see movement. At times you may see reaction in the child, but it's a behavioral response in the child. Probably if it is painful, the child may frown, or the child may clench fist, or anything that demonstrates that there is a kind of sensation, but they are not very, very objective. The scale by Narakas, it is an attempt again by Narakas to classify sensation in the population, but this one is more objective. This is a scale, no reaction to painful stimuli or any other stimuli. Therefore, you do not see any reaction on the baby. Then we have reaction to painful stimuli, but none to touch. Therefore, when you massage the baby, you don't feel anything. There is no reaction. Can you hear me? Okay. Then, but when you pinch the baby, you now see reaction, like the way we have it on flag scale. Then you now say, okay. Then S2 reaction to touch. Here in reaction to touch, you touch the baby, you feel as if the baby really what do you call it, understood that you touch it, but not to light touch, meaning that when you have light touch using like let's say cotton wool, the baby does not react. Then the third one is apparently normal sensation, meaning the score of 3 is apparently normal sensation. Where even with light touch, you apply, the baby moves the hand, then you now understand that the baby is having sensation. Therefore, the highest score is the one with normal sensation, even with light touch. The score of 2 is the one light touch does not elicit any response, but when you touch very well, like you stimulate, the baby now reacts. Then for 1, you have react only to painful stimuli, even the touch does not do until you pinch or you put little pinprick, then you now see reaction in the baby. Then 0, no reaction at all. Therefore, whatever you do, whether the pinprick, whatever, the baby does not react, that is 0. That is what Nerakas did. Therefore, probably we add to our little passive range of passive movement, our little tactile stimulation, we add it, though the tactile stimulation is what is being harnessed here to bring about the Neraka sensory grading system. Okay, now we move to electrodiagnostics test. Therefore, when you are managing, we said you reach, I have seen literatures, the one we are using, the chartered physiotherapist recommendation, they recommend 8 weeks, but I have seen literatures that said up to 3 months. That if you are managing a baby up to 3 months, 8 weeks is like 2 months. If you are managing up to 3 months and you are unable to see anything, it's good to have discussion with the referring, what do you call it? The referring pediatrician. If they can do some further investigation and see whether the nerve damage is not neuropraxia, it is likely axonotmesis or neurotomesis. Therefore, electrodiagnosis text, we want to get the extent of the injury, and then therefore we can also track recovery. Then we can also, if the therapist can do it, he can do it himself, or you can ask for electromyographic test, needle electromyography. You now assess for the latency, the distance, what do you call it, the speed of conduction velocity in the nerve, whether something is happening. Then we have what you call it, amplitude of compound muscle action potential. All these ones are electromyographic test. At times, some neurologists do it. Like in Kano, I know of a neurologist that said he can do it. Then, but this is also repertoire of physiotherapy. If you can learn it, you can also do it. Complete nerve conduction studies can be done, or interoperative somacentric evoked potentials. We have so many of these guys that can be done to ascertain the extent of the nerve injury. But remember, we said you can also order for radiological assessments. And the next is the X-ray. Yes, X-ray can verify whether there is clavicular or humeral fracture. The CT can evaluate root avulsion with sensitivity of 58 for postganglionic rupture and 72.2 for preganglionic nerve root avulsion. The magnetic resonance imaging MRI will detect root avulsion at an overall sensitivity of 75 and specificity of 82, meaning that they can also detect whether there is nerve damage, or you can use non-invasive ultrasound to provide information on the nerve. Generally, when physiotherapy starts managing and after 3 months, 4 months, the child is not really doing well, then we can also have a discussion with them. Okay. Now, we have now started doing active assessment. We now want to study the active, movements of the affected hand. Then we have active movement scale and Toronto scale. For infants, these ones are the ones that have been cleared to be used. We have active movement scale and we have Toronto scale. These are the two that have been cleared, and we are going to discuss them. The first one we said is designed to be used from birth to 1 year. But it has one advantage: it can be used up to adolescence. Then what is this active motor scale or active movement scale? This active movement scale actually assess movements of up to the movement of joints of the upper limb by grading them from 0 to 7. But the two movements that occur, we can have movements in gravity counterbalance position, just the way we have muscle power grading. All movements in gravity counterbalance position will be scored from 0 to 4. We are going to see the scale. All movements that are performed against gravity will be scored from 5 to 7. And we don't want any score to be less than 4. Therefore, for the global score, for each of the muscles we are going to test, we are going to test and score the muscle from 0 to 7. But all movements that are in gravity counterbalance position or in gravity minimized position are going to be scored from 0 to 4. All movement are going to gravity will be scored from 5 to 7. That is how the active movement scale is. Okay, now it is used to document upper extremity function during treatment and recovery, meaning that in research you can use it to assess the baseline, and you can use it to assess improvements or deterioration if there is any. Then I have said it, there are 15 active upper extremity movements that are tested in both gravity eliminated and against gravity positions. Each movement is recorded from 0 to 7, but remember we said in gravity counterbalance position 0 to 4, and then against gravity 5 to 7. Now, this is the first information. Look at the fourth bullet. Refer at 8 weeks if shoulder abduction and shoulder flexion are less than grade 4. You can see, based on the pediatric chartered physiotherapist recommendation, they said if shoulder, meaning that this is significant. I think it is answering, what is it about today? Is answering your question now. They are saying based on this scale, yes, based on this scale, if the shoulder abduction and flexion are less than grade 4, based on this scale, that we should refer. But I told you I have seen other literatures. You know, there are so many literatures around that says up to 3 months we should refer, meaning that in this environment, even if you cannot refer, what you just do is you now have a discussion with the pediatrician. This is what the literature says, that we should also have a look again. Probably the injury is not just a small injury that physiotherapists will be able to manage alone. Probably there may be need for further assessment and management, probably surgical intervention. Then the 15 movements, active upper extremity movements, I have highlighted them below here. Under the shoulder, we have almost 5 movements: flexion, abduction, adduction, internal and external rotation. 1, 2, 3, 4, 5. Then in each of the other ones, we have 2, 2. 5 other one: elbow flexion, extension, forearm pronation and supination, wrist flexion, extension, finger flexion, extension, thumb flexion and extension. Each one of them has to be graded from 0 to 7. But they specifically, this is a recommendation, not for me. They specifically said shoulder abduction and flexion, if they are less than grade 4 by the end of 8 weeks of management, that we can refer. But I've seen literatures that said up to 3 months, meaning that 12 weeks. We may not refer, but we may have a discussion with them. It is not that we are not doing well, but probably because of the degree of the injury supersede what physiotherapy management alone can solve. Okay, this is what the active movement scale is all about. Remember, we said it has been validated for use in infants, meaning that for infants, you can use tactile stimulation to get all the movement you want. Therefore, in gravity eliminating position, for each of the group of muscles, no contraction, contraction, and no motion, meaning that one is the same thing with Oxford's muscle power grading, less than 50% of range of motion, meaning that when the child moves the hand, but less than 50% of the full range of motion of that particular muscle or joint, you give him 2. Then greater than 50% of the range of motion, you give 3. But in gravity counterbalance position, then full motion is 4. And then in this scale, AMS, they are telling us when you get the shoulder flexors and abductors, you cannot get in gravity counterbalance position, you cannot get full motion in gravity counterbalance position. Then you should refer. Something is wrong at the end of 3 months. That is what they are saying. The child has not reached the gravity, stage. It is the child is still under gravity eliminated, and he could not get the score of 4 or full motion in a particular in shoulder flexion and shoulder abduction. Then they said we can have a discussion with the using our scales. We can use our scale and our literature as reference. Then we have discussion with them. The movement against gravity, less than 5% of the range of motion, 50% of the range of motion, and greater than 50% of the range of motion, 6. And then when it is full motion against gravity, this is not Oxford muscle power. They did not say against resistance. The only resistance they use here is what? Gravity. That is AMS. Therefore, AMS scale is very easy to understand. It's very easy to use. It's very easy to grade individual muscle. There is no global rating for AMS. It's for each muscle can be graded because they have telling us shoulder abduction, adduction, external, internal rotation, and flexion. Therefore, each one can be done. Then the next is Toronto scale. Remember, in the assessment of infant, I told you 2 scales have been cleared. Initially, it is the AMS that was cleared, but later now, a research based on literature has shown that it is also reliable in assessing infants. Initially, it is designed for children at 3 months of age, and it's also used in surgical decision making. Can now be used in infants. They said the reliability has been confirmed recently. Okay, then what are these motor assessments in Toronto? They say the following active movement are scored. Look at the other one is more global. It assesses 15 movements. But in Toronto test score, we have elbow flexion, elbow extension. Okay, let me tell you another difference. In active movement scale, you assess individual muscle and you give score for individual muscle. There is no global score for the upper limb. Let's say, if you want to assess like physiotherapists, we used to assess gross motor muscle strength in the upper limb. You can say the muscle strength in the upper limb on gross motor is 3 because the individual can raise the hand against gravity but without resistance. That is the global. But we don't have it in in AMS scale, but we have it in Toronto. You can have a general global score. Therefore, we have elbow flexion, elbow extension, wrist extension, finger extension, and thumb extension. Therefore, that is what we have. Rate each movement from 0 to 2. Therefore, rate individual movement from 0, no motion, to 2, full motion. Maximum Toronto score is 10 points, meaning that we have a global score. You can rate based on Toronto. And they said if any child has score less than 3, it is also that, or less than 3.5, we should also refer. Now, look at it. Okay, now observe. In the AMS scale, they are talking about 8 weeks. That is 2 months. In Toronto scale, they are telling you up to what? 3 months. Meaning that you as physiotherapist, you have the chance to keep managing the patient up to 3 months and see whether it is likely the child, respond, or we have discussion with the referring, pediatrician. Therefore, it can use to predict outcome. If the score is less than 3.5 at 3 months of age, poor recovery is likely expected. Referral to tertiary center is therefore required. This group of children may require early surgical intervention. If the score is greater than 3.5, reasonable recovery is likely. Here, in this one, they did not talk about one specific group of muscle. Unlike the MS scale, they are talking about the global score of the hand. Then how do we have the global score? And we are rating, remember, look at the following slide. We are rating each of them from 0 to 2. How are you going to get 3.5? Okay, they have a standard way of doing it. We are going to look at the scale. This is the scale. It's a standard way of doing it. It's the same, almost the same with scoring with the format. Is almost the same with AMS, but in gravity eliminated position and against gravity. Look at it, movement in gravity eliminated position for each of the what do you call it, the muscle group and against gravity. Therefore, if there is no contraction at all, the muscle grade is 0, you give numerical score 0. If you move, contraction again, no motion, the same thing, the muscle grade is 1, but you are not using in the total, scoring. Please, we are not using the muscle grade in the middle. We are using the numerical scoring. Remember, we said we are going to score each muscle. Look at it from 0 to 2. No motion is 0, 2, full motion. Therefore, please, we are not using the muscle grading in the middle. It's just we are using it as a guide. The numerical scoring here is what we use. Therefore, each one of them, contraction, no motion, you are going to give 0.3. Motion in less than half of range, just like the AMS, 0.3. Motion greater than half of range. In gravity counterbalance position, 0.6. Full motion, in the other one we have 4. But in this guy, we are having what? 0.6. Therefore, when a child has 0.6, meaning that he has full motion for a particular group of muscle. Remember, look at it. There are 5. Elbow flexion, elbow extension, wrist extension, finger extension, and thumb extension. These ones, if each one score 2 times 5 will give you 10. Therefore, you assess for each one of them and come with a cumulative score. If we are doing it for elbow flexion, we do it for elbow flexion. Like for elbow flexion, he may have 0.6. For another group, may have 0.6. If we have 0.6 across, it will be 0.6 times 5. That is 3. Meaning that it's less than 3.5. What the Toronto is saying is that minimum in each of the group, you must have full movement in gravity counterbalance position, and at least some of them should move against gravity. That is what they are saying. Then against gravity, look at it. When the child is able to raise against gravity, but in less than half of range, we still give 0.6. But when the motion is greater than half, we give 1.3. Full motion, we give 2. Therefore, when we are able to get for each of the 5 group of muscles, and we add them up, if the score is less than 3.5, at 3 months of age, something is wrong. But if it is 3.5 or greater, then it's likely that the child is going to do well. Okay, with this, we come to the end of the first session. We are able to finish 49 of the slides out of the 90. When we come back, we are going to continue assessment of the older children. Thank you for listening.
Thank you, sir.
Thank you, sir.
Yes, we are going to take a little break. Thank you. We are going to take a little break. Then we come back and continue from the 50th slide up to the end.
Please, what time are we coming back?
We are coming back by 2.
Hello, sir. I don't know if you are still there, sir. I'm raising my hand, sir.
Okay, I'm with you.
Yes, sir. It's about the Toronto scale, sir. I want
Yes.
to ask how often we should do it. Is it at the first presentation, and subsequently, how often should we do it? And then their ages. When a child gets to 3 months, should we try gravity eliminated position or gravity assisted position, sir?
No, I think what they said is, we said AMS was the one that was cleared to be used for infants, and then Toronto was meant for children that are up to 3 months. But now, based on one research, they have found that Toronto can also be used for infants. That's one. And the second thing is, we said we can use it for initial assessment, and we can also use it for reassessment. Since we can assess as infancy, probably after 2-3 weeks of our management,
Yes, sir.
we should be able to assess again and see improvement. Because remember, the literature is saying if you are using Toronto, by the end of what do you call it, 3 months,
Yes,
you
sir.
should be able to see a score of 3.5 or more. If
Okay,
it is
sir.
less than 3.5, meaning that we can be scoring after first 4 weeks, after another 4 weeks, at least to be seeing the rate of improvement that we are going to sustain. I think me is personal. For 4 weeks is okay for somebody to use.
Okay, sir.
Okay, thank you.
Thank you, sir.
Thank you. Okay, good afternoon, everyone. We are back. Let me share my slides. Okay, are we together? We are back. Hello, Hafiz, can you hear me?
Yes, sir. We can hear you, sir.
Okay. Uh, Therefore, we are all welcome back from the 1 hour break. This is 8 minutes past 2, and we said we want to continue. The last slide was on Toronto test score, and the next slide we are going to look at guide to assessment process in older children. Okay. Therefore, we said the following information guide the assessment process. We are now not dealing with an infant or a child within 1 year. We are saying this is a child that is up to 2 years. They are older children. By then, what we are looking at is probably some deficits in the attainment of muscle strength in some muscle groups, probably inability to do some other things, but we are not majorly interested in impairments. We are interested in two now, both about impairment of strength and age-related activities that the child should be able to do. Here we say the history of pediatric brachial plexus injury from birth up to that time is very, very essential. You are likely going to meet somebody whom you have never managed, but he has transferred from another place and you want to start managing the history up to date, then history of surgical management, if there is any, history of rehabilitation intervention received. Therefore, you are managing an older child, or even if it is an older child that you have started managing when he was young, you need to have a review. What have you done from the first time you see this child? What are the likely interventions you are going to include now that the child is going to become older? Then we have assessment of the older child. We have there should be a shift in priority to assessment of activity rather than impairment. Therefore, we have assessed so much about impairment of strength, impairment of range of motion, pain, what do you call it, sensation, impairment of the muscle tone, everything, impairment. But here they said we should start to focus on age-related activities rather than impairment. But they said, however, impairments can limit the scope of desired activities and opportunities for social participation. They said still, even in the older child, if we did not take care of muscle strength issue, we did not take care of range of motion issue, they can still be a deterrent to the child achieving success in the desired activity he or she wants to do and in the opportunities he has for participation. The state is still very important. Then how do we assess them? If we are assessing, what do you call it, impairment and activities in the older child. Therefore, we now move to objective testing in the older child, the evaluation of strength of specific muscle group. For example, the forearm supination, which is the most difficult to come. You can achieve what do you call it, biceps strength, meaning that the elbow can bend. You can achieve wrist extension, but forearm supination may be difficult. Shoulder flexion and abduction may be difficult. Therefore, you may specifically want to see in the older child that came to your clinic, how much has he achieved forearm supination and shoulder flexion and abduction. Then measurement of joint range of motion via goniometry is essential. That this is a new person coming to me. Is the movement restricted because of what do you call it, joint stiffness, or because of contracture, or is purely the restriction is as a result of weakness of the muscles that are controlling the joint? Their skeletal integrity is based on verified by radiological imaging. Therefore, if you are querying anything, probably you are querying fracture, you are querying anything, even if it's an older adult, you saw something that is fishy, the best is to verify by radiological imaging, meaning that you need probably an X-ray. Then now we are moving back to muscle strength, but not in the what do you call it, in the infant, but in somebody who is older. They said the AMS scale can still be used up to 15 years. I remember we said AMS can be used from infancy, before they said 3 months, but now it can be used from infancy up to 15 years of age. Therefore, you can use it to gather information on muscle activation and joint motion. But they said as the child gets older,
Sir, we can no longer hear you.
Yes. Can you hear me now? Can you see?
Yes, sir. We can hear you now.
Okay. Yes, we said, but we have discussed that for the older children, we can still use the AMS, but if they can respond to command, it's better we use Oxford Muscle Power Grading. Then we now have other classification. We have the Mallet classification of shoulder function, the Gilbert-Raimondi score for elbow function, and we have the Gilbert-Raimondi score for hand function. Then let's take each one of them. The assessment of shoulder function, we start with the Mallet classification. It is a motor assessment scale for shoulder joint for children 3 years of age and older. Therefore, if you want to assess children 3 years of age and older for shoulder function, we can use the Mallet scale. Though we even have the modified Mallet scale, but we are discussing the Mallet scale. The child imitates 6 postures demonstrated by the clinician for bilateral hand motion. Therefore, in this case, I said the shoulder should abduct, then the two hands should be abducted. If I say the shoulder should adduct, the two arms should be adducted. If I say the shoulder should be placed at the back of the neck, somebody should do it. If I say the shoulder should be, the hand should be placed at the back, the child should be able to do it. If I say the hand should be brought to the mouth, like I want to blow the palm, the two hands should be done. Then scoring ranging from 1 no function to 5 normal function. That is the Mallet scale. Then here we have it, the Mallet grading. We have 0. Actually, the Mallet grading is accompanied by a picture diagram, which serves as a guide. We are going to look at this this scale and the picture diagram. Let me expand it. Okay, this is the Mallet scale, like the one we are going to look at all of them. It is easy to understand. We have for the one we have flail shoulder. What we mean by flail shoulder, meaning that the shoulder is flaccid. The child cannot use the shoulder. He cannot use it anyway. That is flail shoulder. But when we say flail chest, it's different from flail shoulder. In flail chest, meaning that there is a broken rib. When the child breathes in, the broken rib will now come up very well. When it is going down, he will now go down. Therefore, it's like it's telling you that there is a detachment. That is flail chest. But this flail shoulder, they are telling you no movement at the shoulder. Then in grade 2, we have active shoulder abduction, less than 30 degrees, 0 degrees of external rotation at the shoulder, hand to back of the neck is possible, meaning that you cannot put the two hands at the back of the neck, most especially the affected hand. Hand to back, impossible, he cannot put his hand to touch his low back. Hand to mouth with marked trumpet gesture. Okay, let me demonstrate this one. Okay, look at it. Look at stage 2. We don't have stage 1 here because there is no motion. Therefore, look at stage 2. The first one, abducting hand is less than 30 degrees. External rotation is difficult. You can see 0 degrees. Then hand to back of the head. Look at the affected hand. It's impossible. The affected hand is the one facing you, meaning that the child's right arm, the one facing your left arm. Hand to back is also impossible. Then hand to mouth is like a trumpeter, meaning that he is unable to place the hand to the mouth itself. It's like coming towards the mouth, but you're unable to reach the mouth. That is 2. Let me go back. Observe, this is what is here in 2. Abduction less than 30 degrees, 0 degrees of external rotation, hand to back impossible, hand to neck impossible, hand to back impossible, hand to mouth by trumpet gesture is unable to reach the mouth. Therefore, that is what is happening. If we check it again, this is what is happening. Then let's go back to 3. Look at 3 here. Here we said active abduction between 30 to 90. External rotation now has reach of the shoulder, has reached 20 degrees. Hand to back of the neck, difficult, but he is able to do it. Hand to back, difficult, but he is able to do it small. Hand to mouth, possible with partial trumpet gesture, meaning that the mouth now has the hand now has reached the mouth small, but still it's like trumpeting. Then we now go back to the picture. This is the picture. You can see 30 to 90 degrees abduction. You can see up to 20 degrees of external rotation on the right hand. you can see hand to the head is difficult on the right, if you can see my cursor. Then hand to the back, look at the left, it's very okay, but the right is difficult also. Then now you can have the mouth, hand almost reaching the mouth remains small. Then the last one, the fourth one, okay, let me go to the fourth one is active abduction to 90 degrees. You can see it on this table. External rotation more than 20 degrees. Hand to back is neck is easy. Hand to back is easy, and hand to mouth is easy. Now the individual can put hands in the mouth. Therefore, you can see it here. Greater than 90 degrees. This one is not as straight as this one, but at least it's greater than 90 degrees. Greater than 20 degrees of external rotation. It's easy to put the hand at the back of the neck. It's easy to put hand at the back near normal. It is easy to put hand in the mouth. Then the last one is normal shoulder, meaning that in this particular in the pictures here, we don't have grade 0 and we don't have grade 5 because they are normal. All the hands will demonstrate everything similar. Okay, now we now move to assessment of shoulder function. The second assessment, we are done with mallet assessment. We are moving to Gilbert Raimondi shoulder function assessment. We call it the Gilbert scale. The Gilbert scale is also simple, but actually mallet is easier. We have flat shoulder, meaning that there is no movement at all. Abduction of the shoulder or flexion up to 45 degrees, but no active lateral rotation, just like the other one. Remember, the major problem with Erb's palsy is there is internal rotation. The what do you call it? The deformity is adduction and internal rotation. Therefore, when we are assessing the hand, we are assessing abduction and external rotation. That is it. Then we now have abduction and flexion up to 45 degrees. Then we now have no active external rotation too. Then we now have abduction less than 90 degrees, meaning that this guy can pass 45 degrees, but it's not up to 90 degrees in abduction of the shoulder. Lateral rotation is in neutral, meaning that he cannot go beyond neutral, meaning that he cannot go beyond normal standing position. The hand is no more facing the body, as in like you want to put your hand in your pocket, side pocket. Now the hand is like facing forward, like in what do you call it? In normal anatomical position. It cannot go beyond that one. Then they said abduction. Now in stage please, it's 1 to 5, please. In stage 3, we have abduction up to 90 degrees. We have weak lateral rotation. Then we now have abduction greater than 120 degrees, meaning that shoulder abduction can reach up to almost 170 degrees of shoulder abduction. Therefore, greater than less than 120 degrees, incomplete lateral rotation. Then abduction greater than 120 degrees, and then we now have normal, meaning that one can abduct almost up to 170 degrees. Then we now have medical research council system for elbow function. Therefore, what is recommended is that we should use the medical research council system for elbow function. And then we know it is the Oxford muscle power grading, no contraction 0, flicker of movement and no motion 2, 1. Then active motion in gravity counterbalance position or eliminated position 2, 3. Active motion against gravity, 4. Active motion against gravity and resistance, then 5. Normal power. Therefore, this is for elbow. Then we now have Raimondi's assessment of elbow function. Here in the Raimondi assessment of elbow function, we have 3 assessments for each of the 3 elbow functions: elbow flexion, elbow extension, and elbow extension deficits. Elbow flexion, elbow extension, and elbow extension deficit. For elbow flexion, nil flexion or some contraction, incomplete flexion and complete flexion is easy. Then we now have extension, no extension, weak extension, and good extension. And then for deficit, 0 to 30, meaning that individual, what do you call it, who has deficit from 0 to 30, and what do you call it, 30 to 50 and more than 50 degrees of deficit in extension. Therefore, you now start with extension. Therefore, if one is able to have full extension, almost 180 degrees, no deficit. But if one is able to extend small, it is only 0 to 30, we give 1. Then between 30 and 50% of extension deficit, 2. Then between 30 and 50 extension deficit, we give 3. Then we have Raimondi assessments of hand function. It is also given in 5, what do you call it, 6 points grading from 0 to 5. Complete paralysis of the fingers. Then we now have limited active flexion of fingers, no extension of the wrist and fingers. Up to, I don't have to mention all these guys. Ours is to go and revise the Raimondi motor assessment scale. We can also download it. We can also go on to get more information on the what do you call it, Raimondi hand assessment. Then the next thing in the children we want to assess is activity and participation. Remember, we said for young children we look at more of impairments because we want to see where there are impairments in range of motion, impairment in muscle strength, impairment in sensation, impairment, all these guys. But when older children, we are interested in both impairment, activity, and participation, which is very, very important. They say the focus of clinical care shifts from impairment to age-appropriate activities and participation. They said children who sustain pediatric brachial plexus injury are at risk of restriction in activity and participation, meaning that the child may not realize that there are deficits in what he can do until when he grew up and he wants to do something with the hand or participate in some activities that are age-related, find out that he has deficit. That is when they will now begin to come back to physiotherapy again. They said the assessment of this aspect are based on the ICM framework, that is International Classification of, what do you call it, Functioning, Disability and Health, that is ICM. We have discussed impairment extensively, range of motion, pain, and strength, and other ones. Therefore, the interest is on activity and participation. You know, WHO has defined, before we don't, there are 2 classifications of WHO. We have what you call the ICIDH 1980 and the ICF 2001. The ICIDH 1980, the classification is that of impairment, disability, and handicap. And later, they saw the need to revise the classification based on some prevailing psychosocial issues. One of the issues is that people are being stigmatized rather than calling somebody who has inability to see or inability to walk, we call him disabled. Look at this leopard. This is a disabled person. Therefore, there is need for revision because the words is being used to stigmatize people. Therefore, they now change disability to activity limitation. Therefore, when we are assessing activity, in essence, we are also trying to assess activity limitation. Things that the child is unable to do that are age appropriate, meaning that forms his own level of disability, we assess it. Then participation, before now in ICIDH 1980, it is called handicap. And then we do no longer use handicap, they call it participation restriction. Therefore, wherever a child is not able to participate in life situation, he is unable to play like other children, unable to assess what do you call it, recreational abilities like other children, unable to go for physical exercise and play like other children, then is having participation issues. Then we now have to date, I think we have only one instrument that is used to assess activity and participation in children with brachial, what do you call it, pediatric brachial plexus injury. It is called the brachial plexus outcome measure. It is designed to assess activity and participation. It has 2 parts: the activity and self-evaluation scale, meaning that the physiotherapist will assess activity, and then the child, as you sit down with the older child, you now train him because it uses a FACES scale that, okay, how will you evaluate how you satisfied you are in doing your activity based on this scale. Then the child will now assess his activity, what do you call it, evaluate his satisfaction. Okay, the activity scale has 11 tasks, which are components of the 15 movements of AMS. Remember, we have 15 movements of AMS. Therefore, they pick 11 out of them to form the task. But this time around, the task is not done by you stimulating the child. The child, you give command, the child is able to do it. Then you now assess the activity. The activity performed is graded from 1 cannot complete to 5 complete or normal. Therefore, I was able to snap the what do you call it, brachial plexus outcome score. But the major problem is that the length of the thing comes in PDF. It is free online. You can easily browse and take it down. Look at the scoring here. Functional movement scale cannot complete all these ones up to 5. Then each of the items, you can see there are 11, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. You have 11 items, and each item, it starts from shoulder, elbow and forearm, wrist and finger and thumb. Then each activity you ask the child to do, if he's able to do it 1, if he's unable to do it 1, if he's able to do it up to 5, then you now grade the child. That is it. And the self-evaluation scale, then is part of what do you call it, the scale, which is down. You cannot see the self-evaluation scale. When I snap it, is the scale is far larger than the window. That is why you cannot see the self-evaluation scale. The self-evaluation scale is for the child to evaluate what do you call it, the way his hand works, how satisfied he is with the hand. That is meant for the older children. Okay, now we now come to physiotherapy. What are the physiotherapy approaches to the management of these children? We said physiotherapists will have to assess the need for resting hand splint for positioning and protection. You may need an aeroplane splint for a small child. In some instances where there is risk of shoulder subluxation, at times people advocate that you can use something on the wrist of the child to just stick to the pillow, so as to what do you call it, obtain lateral rotation and abduction of the shoulder. It depends on what you want to achieve. You may need a cock-up splint in order to encourage wrist extension, but I always encourage cock-up splints, or most of the splints that we want to use, we should use them in the night. In the morning, we should give room for activity to take place in the hand, such that other stronger muscle groups should not become weak due to restriction in splint. You can use air splint. It's a splint where you apply in the hands of the child. And if you want to do weight bearing in sitting, the way we used to do to stroke patients, weight bearing in sitting, you can just pump air. That will serve as like a back slap for you. It will hold the hand for weight bearing activities in the hand. If you want to achieve external rotation in sitting and what do you call it, an extension of the wrist in sitting. Then physiotherapy should promote activities and exercises to maintain range of motion and promote recovery of the muscle, meaning that our exercises, our range of motion exercises should be able to take part here. We should encourage, we should do it, and then we should also encourage. If it is an infant, majorly we do passive. If it is a grown-up child, we do assisted active. We can do sensory stimulation to promote increased awareness in the arm. Yes. For older children, when we encourage bilateral arm activities, whatever the child wants to do, we ask the child to use the 2 hands. That is also part of sensory stimulation. The child will not forget the affected hand. Then for us, the therapists, we can always do the brushing, we can always do the massaging in order to increase awareness of the affected arm. Provision of splint to prevent secondary complication, we have said it. Constant induced movement therapy, mostly we apply it on older children. Research have shown it is also useful. We can constrain the affected hand, unaffected hand, while we promote the use of affected hand. But in older children that can obey command, electrical stimulation may be beneficial. Up till now, researches are still going on the benefit of electrical stimulation. Then we now have evidence-based management. We got this was from what do you call it, systematic reviews and meta-analysis of studies. When we say systematic review, what it does is it gathers all the studies that have been conducted on a particular condition, and then all the treatment approaches to managing a particular condition that have been reported, either RCT, majorly RCT. They will now gather all the results of the RCT using a proven scientific method and now come with a conclusion whether a particular treatment modality is useful or it requires further research. That is the systematic review. They say the systematic review by Dimatos et al. 2023, that it is done last year, concluded that physical therapy intervention alone combined with other treatment modalities, are effective in improving short-term disabilities in children with brachial plexus. Therefore, what they mean is that physiotherapy can improve short-term disability, meaning that long-term disability, probably individuals with extensive injury that may lead to long-term disability may not, physiotherapy may not take care of that one. The patient may have to undergo surgery so as to prevent long-term disability. Then systematic review by Palomo and Sanchez reported that constant induced movement therapy and kinesiotherapy and electrotherapy, most especially electrical stimulation and virtual reality and use of splints and orthosis, improve all upper limb function from 0 to 10 years, meaning that physiotherapy modalities that we used to use, either constant induced movement therapy or taping, like you can tape the shoulder to achieve abduction, electrotherapy like electrical stimulation, virtual reality. But in most of these instances for older children, though they say 0 to 1 year, but mostly kinesiotaping can start from the from infant. Infant skin is very, very delicate. At times you use taping to mobilize the hand and the shoulder. Then electrotherapy can start. Virtual reality for older children. Orthotics devices usually for older children. Then we have a systematic review commented that efficacy of adding kinesiotherapy to physical therapy program to manage children with brachial plexus is still questionable. Therefore, what they are really saying is that kinesiotherapy, in addition to physical therapy, to manage children with brachial plexus is still questionable. Meaning that whenever you are doing massage and they say they should add kinesiotherapy to it, probably they say it may not add anything. Okay. Then we have another systematic review by Gobet et al. 2010, who identified 4 groups of indicators for use of Botox injection. And these 4 groups of indicators that internal rotation, adduction, contraction of the shoulder, meaning that when an older child came with you with internal rotation and adduction, meaning that he has not achieved anything, and then the shoulder has become contracted, meaning that there is no internal, because the deformity in shoulder is usually internal rotation and adduction, and it remained like that, meaning that he has never had physiotherapy before. Then they said botulinum toxin injection can help with releasing of that contraction. Limited active elbow flexion, meaning that if the hand is in full extension and he has not been managed properly, now contraction has set in, or severe contraction has set in. Then they said limited active elbow extension and pronation contraction of the lower arm. All these ones, remember we said Botox injection, botulinum toxin injection is meant for focal spasticity or contraction, where you can identify, it's not global, not in the whole hand, but you can identify a specific area where there is contraction, then you can apply it for release of the contraction. Then another evidence base by Buchanan et al. Concluded that Botox injection has overall benefit in treating contractures seen in patients with brachial plexus injury. What they are saying is, whenever you have somebody with core contractures in the hand as a result of poor management or as a result of not coming for physiotherapy on time, they said botulinum toxin A has a strong beneficial effect in management of contractures in these guys. Then now we have said some physiotherapy approaches, and we have seen systematic reviews on the effectiveness of physiotherapy approaches in the management of children with brachial plexus injury. Then we are now going to see the summary of management recommendation from Association of Pediatric Child Physiotherapists. Here, I borrowed heavily here, nearly in some instances, verbatim what they said is what I picked. But I did that for the overall benefit of the listener. Therefore, this is a summary of the management recommendation. Therefore, most of the management recommendations are for children, infants. Then we have few recommendations in 2 slides for older children. Now, guidelines of pediatric chartered physiotherapists. We have guideline 1 is divided into 2. The guideline can be either for positioning and handling and advice to caregivers, or physiotherapy handling program. Therefore, positioning and handling, they said, now this is each one, I think, is followed by a picture or a diagram for us to see what they want us to do. They said we should give advice to caregivers that they should gently move the baby's affected arm and they shouldn't pull it. Pulling is what causes brachial plexus injury. Then they shouldn't pull it. 2, they do not lift. They do not lift the babies under the armpits. Yes, just like the way we said in children with we have said it somewhere in children with CP that are very spastic. We shouldn't pick them under the armpit because it increases extensor song. But these guys, because the shoulder is either dislocated or they may have shoulder pain, or therefore they shouldn't just lift the babies under the armpit. And then it is recommended that they should always support the arm with the shoulder, elbow, wrist, and hand in neutral position. The advice is that they should wrap the baby in a blanket when moving, which makes handling easier in the early weeks. Therefore, whenever you want to pick the baby, wrap the baby in what do you call it, in a blanket, and lift the baby like that, rather than so that you don't make mistake and lift the arm or the elbow or the hand. Therefore, the two hands are always together. The woman or the mother wraps the baby and carries the baby. Then advice to caregivers continues. They should keep their baby's arm close to its sides in a forward position when holding or feeding. What they mean is that when the child is lying down, they should always keep the hand very close to the child. They shouldn't be far away for safety's sake. And then when they want to feed the child, and as the child is sitting, they shouldn't allow the hand go back. They should put the hand forward. Or at times, if the child is sitting down, they can put something such that the elbow can be flexed. You know, the major problem with this is, one of the problem is there is elbow extension, a lack of what do you call it, elbow flexion. Therefore, they can put their hands forward and probably bend the elbow and put the hand on a pillow. That may also help. Then support the baby's arm with a roll-up towel to keep the arm in neutral position when the baby is lying on its back. They are saying when the baby is lying on its back, like facing the ceiling, then they said we should have a roll-up towel to support the baby so that the hand can be in neutral position. Okay. Then they said we should start dressing with the baby's affected arm, meaning that whenever we want to wear clothes, whenever the parents want to wear clothes for the baby, most especially if it requires putting on the arm, then they said the affected arm should go first, then and undress with the unaffected arm. Therefore, when you want to undress the baby, the unaffected arm should come first. Then it will release tension when the affected arm is coming up. And then when they want to wear the clothes, the affected arm should go inside first, because when the unaffected arm is coming, there will be some pressure on it also. Then we now have sensory stimulation, and we said we should advise parents to move both hands equally. Therefore, when the mother is playing with the child, you should encourage the child to move the hand closely, almost the same time. They can help by lifting the hand so that the child will have sensation of movement on the other hand. They said hold and gently massage the arm, meaning that it's not only the physiotherapist. You can always tell the mothers to always hold and massage the affected arm, such that the baby can have what they call it, some sort of stimulation in the affected arm. Then they said they should place the baby's arm on breast or bottle during feeding. What do they mean? When they are feeding the child, they should fold the arm across the chest or place it on bottle. What they mean is on bottle is that when you are feeding the child on feeding bottle, then the affected arm should like follow the feeding bottle. It's like you holding what do you call it, a bottle of Coca-Cola and drinking. If the mother is feeding the child, then she should take the child's hand and put on the feeding bottle so that the child will have some sort of stimulation on the hand. Then they say bring the baby's hands together to their face, promote visual attention. Therefore, if you are holding something, the two hands should be in the midline in front of the child's head so that the child should be able to see the other limb, and then to stimulate attention on the hand. Then they said encourage weight bearing through the baby's affected arm. Yes, we have been doing this as physiotherapists, and we said we can use air splint, you can use anything to ensure weight bearing. When the child is sitting, you can put weight on the affected arm, support the elbow joint. You can encourage external rotation of the hand, you can encourage extension of the hand and external rotation of the shoulder. And weight bearing can increase the strength. This provides proprioceptive input and can also contribute to skeletal growth. Okay, physiotherapy handling techniques. Okay, they said to prevent stiffness in the affected arm. That is our aim. To encourage functional use of the affected arm, to increase awareness of the affected arm, to promote timely attainment of developmental milestone, then to introduce age-appropriate developmental activities and to advise and educate parents on appropriate management they should do. Okay, then they said physiotherapists also do range of motion exercises. Range of motion exercises are important for maintaining muscle and soft tissue length, maintaining joint range of motion, and aiding development of joint congruity. Now, here we are now moving to specific activities for the child. They say for a baby who has sustained a fracture, range of motion exercises may be delayed up to 3 weeks. What they mean is that, remember we said that in our assessment, initial assessment of all babies, we have to assess for the likely presence of fracture that may be a cause of pain. Therefore, when a child has fracture, is unhealed fracture, they said we can delay it up to 3 weeks for the fracture to heal. Therefore, meanwhile, we can support the child. That is where the splint comes in, at least to support. Then in acute injury, it is recommended not to start shoulder mobilization until 48 hours with reference to 5 days. What do we mean by active injury? We do not mean by active fracture, no. Somebody who sustained, a child that sustained brachial plexus injury and is irritating, this is an acute brachial plexus injury. We shouldn't start moving, and it's even painful to the child. We can leave it until 48 hours or until after 5 days. By then it's subsided, then we now can start. But for fractures, any other thing, fracture, anything, we have to wait until the fracture has healed. Then we now have specific exercises. Okay, here we said, this is the guideline they give. Physiotherapists can do it in the clinic, and we can also encourage parents to do it. At times we use pictures to show them what to do. At times we do it ourselves. Here we start with shoulder flexion exercises. They said this should be done. Please, all exercises that I am going to highlight now based on the recommendation of the chartered physiotherapist, they are to be done at least 3 times in a day. And I have said in the beginning of this workshop that we're supposed to be seeing individuals with brachial plexus injury daily, and if there is need 2 or 3 times even daily, in order to promote quick recovery. They said for us to encourage shoulder flexion, they say we should gently grasp the baby's forearm and hold the scapula down and firmly with the palm of your hand. We assume that we have grasped the forearm, and then we raise the arm slowly up over the head to keep the arm close to the air and hold. This is what they mean. Here, we should support the side of the chest. We should also prevent scapula from winging. Therefore, immediately you put your hand, you can see the movement of the scapula. You can easily, with one of your hand, you can hold the scapula such that it is only the hand that moves, the scapula does not follow. Then when we hold the forearm, then we now raise the forearm. That is what they said for shoulder flexion. That is it. Yeah, that is it. Just really grasp the baby's forearm. The baby's forearm and hold the scapula down. Yes, you hold the scapula so that the scapula does not follow the movement firmly with the palm of your hand. Then raise the arm slowly up over the head, keeping the arm close to the air and hold. That is it. This movement encourages flexion and external rotation of the hand. Then another movement, we have shoulder external rotation. Here we say with the baby in supine line, raise the baby's shoulder and sideways behind the elbow, and bend the elbow to 90 degrees. The baby is in supine. We raise the baby's shoulder sideways, meaning that we open the hand a little bit and bend the elbow to 90 degrees as if we want to say hi. Then we now say, maintaining this motion, rotate the baby's arm back so that the arm touches the bed and hold. Therefore, this is what they mean. As the baby is lying down, you rotate the arm a little bit. That is external rotation of the arm to 90 degrees. Then they said, look at it. This is the initial. We bend the arm to 90 degrees. Then we now raise the shoulder. We are rotating the shoulder, external rotation of the shoulder, external rotation of the shoulder. This is the beginning position. If you can see my cursor, this is the beginning. And then that is the end. Following that arrow, that external rotation has already occurred. Therefore, if the baby is lying down, the back of his hand will touch the bed. That is what they mean. Now they said with the baby in spine line, raise the baby's shoulder sideways and bend the elbow to 90 degrees. Then we now said maintain this position, rotate the arm so that the palm of the hand touches the bed and hold. That is it. Then the next one is, they said forearm supination. We want to encourage forearm supination. They said bend the baby's elbow to 90 degrees. The baby is lying, we bend the baby's elbow to 90 degrees and keep the elbow stuck to the side of the body. Therefore, if you have two elbows, we bend them to 90 degrees, then we stick the elbow to the side of the body. Then turn the forearm out so that the palm faces the baby's face and hold. And we said the baby is supine. Therefore, when the hand is stuck to the body and it's 90 degrees, we now turn it in such a way that the hand is facing the baby's face. This is probably the most important exercise. This is what is happening. Therefore, we have the hand is bent, and then we now open the hand such that the hand will now faces the baby's face. It's like it mimics some Muslim prayers or Christian prayers. When you are praying, you raise your arms. Your hand will be facing your face. When you say Amen, you now rub your face with your two hands. That is it. Therefore, they bend it to 90 degrees. After bending to 90 degrees, then you now turn the hand to face the face of the baby. Then you can do it several times. That is supination for you. Then they said elbow flexion exercises. Keep the baby's palm turned up. Then hold slightly above the elbow. Hold slightly above the elbow, above and below the elbow joint with your hand. Then gently but firmly strengthen the baby's elbow and what? Hold. Then bend the baby's elbow and hold. This is what they mean. Let me show you the picture. Then we now go back. Here, they said we should support by holding the upper part. The picture is showing as if it is holding the physiotherapist or the caregiver is holding the shoulder with the other hand. No, it should hold around the biceps, just slightly above the elbow joint. Therefore, you now use the other hand, hold the elbow joint so that you flex and then you extend. You flex and extend. Therefore, the first one, look at it. They said we should keep the palms turned up. Therefore, we turn the hand up as if we are supinating. We are laterally rotating the shoulder. That is what they mean. Then the chest slightly hold above and below the elbow joint. Therefore, you now come above and below the elbow joint and hold the arm with one of your hand. Then the third one, they said, gently but firmly strengthen the baby's elbow and hold. We now make the elbow straight and hold. Then bend the baby's elbows and hold. Therefore, we use the other hand. With our other hand, we now bend the baby's elbow. You can use two hands. One supports the elbow, then the other one moves the elbow from full extension to flexion. That is what they mean here. Okay, now baby in sitting posture. You can sit, forearm supination and pronation. You want to encourage pronation and supination. Remember, the most important is supination. The child can pronate, but at times, if you want to achieve supination, you have to supinate, then allow the hand to come into pronation, then supinate again. That is what they are saying here. Then we said we keep the baby's elbow bent at 90 degrees and the forearm against their body. Therefore, you can have it. I can sit down, bend my elbow to 90 degrees such that my forearm can be resting on my laps. Then they start with the baby's arm turned down. Therefore, it's like putting my two hands to hold my knee joints in sitting position. Then turn the forearm up until the palm is facing upward. Therefore, we now turn the forearm up until the hand is facing the ceiling. Then they said, turn the baby's forearm until the palm is facing down and hold. Therefore, we now turn it back until the palm is facing down and hold. Therefore, this is it. You can sit the baby down. When you sit the baby down, then you bend the elbow to 90 degrees. Then the baby will now be therefore the forearm will now be resting on your laps. Then with the hand facing down, meaning that holding onto your knee joint, then you can now turn the hand so that the hand will face up. Then turn the hand, it will go down. Turn the hand, it will face up. Therefore, the therapist can do. You can teach the what do you call it? The parents do it. The essence of putting the hand, the baby in sitting position, and then at 90 degrees, you want to isolate the movement. The movement is now done isolatively. If the child is supine, there will be concomitant movement of the shoulder joint. Therefore, bending the hand, even if it is in supine position, bending the hand would allow only movement will take place at the what do you call it, forearm. Therefore, even if the baby is in supine line, when the child is supine line and you support the hand in 90 degrees, you can easily open the hand to face the baby's face and then to face away. At least we get pronation and supination. Then wrist and finger extension exercises. Here they said we should hold the baby's wrist in one hand and the baby's hand in the other hand. Meaning that the wrist, if I use my two hands, one of the hands will be holding the wrist to stabilize, and the other hand will be in the other hand. Therefore, my hand will hold the fingers, the other hand will hold the wrist. Then they said, gently extend the wrist backward, meaning that we should extend, meaning that we should, what do you call it? Extend the wrist, the wrist joint, then extend the fingers. Use the same wrist motion above to extend the thumb of the hand. Therefore, what they are saying here is, look at one of the hand is holding the wrist joint, the other one is holding the fingers. Then we can use the same thing. We can support one of the hand in the wrist and then extend the thumb. Therefore, we can do this as physiotherapists, or we can also teach the parents to be doing it. Then home-based activity or exercises. These are the recommended. They say we should give this as home-based exercises for the parent. They say we should place the baby on their side with their affected arm highest, meaning that if the right arm is the one affected, then the child should lie down on the left side such that the right arm will be up. If the left arm is the one affected, then the child should lie down on the what do you call it, right arm, so that the left arm will be up. Then they say place a large roll-up towel or bolster. Bolster is something we use in pediatric rehabilitation, look like small drum, like you fold a very big towel. That's a bolster. It's not really at the back, and other one in the front. In essence, that is what they mean. Here, I got this picture from them. You can see we have a bolster behind, and then we now have one bolster in between the two legs. Then we now put a ball so that the child can be reaching with the hand below and the hand above. The hand above is free to move, is the one that is affected. The hand below is the one that is not affected. Therefore, in a way, you are encouraging movement of the upper hand. They say we should put toys in front of them, meaning in front of the baby, and to encourage activity of the uppermost arm, the one that is affected. Then we move to the next activity. They say we should give activity in supine line. Remember, we said it's part of our activity as physiotherapists, even in the clinic for neonates, when the child comes, and then we now play something that makes sound, like rattle that make noise, and the child's attention is being cut off. Therefore, you can encourage the child to hold that particular rattle or something that is making noise in form of play with both two hands. That will bring about perception, that will encourage awareness of the arm, and it will encourage active movement the arm. They said the baby lies on the back, then suspend or hold a toy above them. Therefore, if a baby lies on the back and you suspend or hold a toy, then the child will just be looking at the toy, creating interest in the toy or something that is making sound. Then they said encourage them to reach forward, particularly with the affected arm. You can also be moving that thing towards the affected arm so that you encourage the baby. One may need to gently hold back the unaffected arm at times. What they mean is that when you see the child is moving the unaffected arm to play with it, you may likely use your arm to hold the unaffected side so as to promote the use of affected side. Therefore, what they mean here, look at it, the child is playing, and then you look at a star that is being hung above, and then the child is encouraged to use both hands to play with it. Then they said activity in sitting. In sitting posture, place your hand on the baby's arm or elbow to assist them in a two-handed activity, such as reaching for a toy or clapping. Therefore, meaning that physiotherapists can help the child as the child is sitting. You can sit behind the child, and then when the child wants to reach for a toy, you can help by raising the other hand so that the two hands can hold the toy. You can help the child by clapping the two hands together. You can do so many things by just supporting the hand. They say this encourages coordination between the affected and unaffected arm. Here, this is it. The child can be, you can place the child in sitting posture. I trust pediatric physiotherapists, most especially ladies, they used to sit down on the couch. Every treatment is done in sitting, the child's on their lap, and they do a lot to help them. Then we now have older children. Therefore, the recommendation in this, the pediatric chartered physiotherapist recommendation for older children, they said in the early school years, meaning that by the time the child has reached 3-4 years and they want to start going to school, they say general muscle strengthening should take place as part of daily activities and regular structured physical and education PE session, physical exercise session. What they mean here is, as the child is going to school, we should design activity that will promote active use of the affected, arm. Most especially, we should design activity that will promote the desired movement. Like, for example, if supination is the one that is missing, we should design activity that will promote supination. Like, let's say screwing. You can say, okay, madam, yes, I have a screw and I have, I want the child to be screwing this and then to be opening the screw every day so as to promote pronation and supination. You give them. Then you can also design activity for the clinic as they come from time to time. They say it's essential for children to continue with appropriate stretching exercises throughout the entire period of their growth. Therefore, if there is need for bending, most especially for elevating the hand above shoulder, and it can be always done, even when the child is being discharged. You can ask the mother, let the child be raising his two arms up every day, raising one arm, raising two arms, playing with something, such that the stretches in the shoulder, the stretches in the elbow, the stretches in the wrist can be done. Then they said home-based stretches need to have been taught, are reviewed, and updated by pediatric physiotherapists, meaning that when you give home-based exercises, then they should be coming down so that you review and then you see the progress and then you now ask them to continue. Then they said two-handed activities should always be encouraged. Yes, but which two-handed activities? Now they said children should avoid hanging, which requires strong arm pulling. Yes, if you see the child want to hang or want to hold on to something to hang, you said no because of fear of shoulder dislocation. We say we encourage pushing, not pulling. Therefore, it's better you encourage a lot of pushing. When the child is pushing, you are increasing the muscle strength in the arm. You are encouraging supination. You are encouraging some other things. The child can pull, but the amount of weight the child pulls should also be gauged. Even if it's me lifting, the ball the child will lift, the weight the child is going to lift matters a lot because of trauma to the shoulder. Throwing and catching activity need to be modified. If there is weakness, therefore, if there is weakness, even throwing and catching because of shoulder dislocation. And then we now move to prognosis. They said Palsy carries the best prognosis of recovery when we compare it with Clomicus palsy, when we compare it with Erb's Clomicus palsy. However, they said the recovery depends on the degree of nerve injury. Therefore, for somebody who is having neuropraxia, he does better than somebody who is having an axonotmesis, and is best than somebody who does what? Who has neurotmesis. They said complete recovery is unlikely if no improvement is noted within the first 2 weeks. Therefore, they said complete recovery is unlikely. What they mean is that no matter how little, there should be little improvement in what you are doing. Even if it is in one joint, you should see something. If not, there will be improvement, but there may not be complete recovery. And they said muscle atrophy from neurotmesis begin 3 to 6 months. Meaning that if somebody is having neurotmesis and there is no reconstructive surgery to help the child and he has neurotmesis, they said muscle, atrophy will set in between 3 to 6 months after injury. And by 1.5 to 2 years, it's likely going to be irreversible. And with this, we say thank you for listening, and we now enjoy our discussion session. Thank you very much.
Grandma, but that was like oh, and get but that was like oh, and get
Hello. Hello. Hafiz.
Hello, good afternoon.
Okay, I
Good
have
afternoon,
reached
sir.
the end of today's lecture.
Okay, thank you for the lecture.
Okay, I have somebody who raised hand. Coyote. Coyote, are you with me?
Good afternoon.
Good
Good afternoon,
afternoon.
Coyote. Yes,
Sorry.
Coyote raises his hand.
Yes, good afternoon. It's
Good afternoon,
I'm
how are
home
you?
and I'm using my husband's phone. That's why it's
Okay,
showing.
okay,
Yeah, thank you.
thank
I
you,
have
ma'am.
a question to ask.
Okay, ma'am.
Thank you, sir.
Questions, yeah.
Thank you.
Okay,
Okay, so thank you very much for the presentation once again. I really
thank you, ma'am.
thank you so much, sir. My name is Titi Olagbayi. I'm a physiotherapist from Benue State. I want
Okay,
to
ma'am.
ask,
Okay,
you mentioned that Botox injection can help with contractures.
yes, ma'am.
Contractures. Now, in my
Yes, ma'am.
practice, I've worked with many children in CP cases, and we're not really in EPS Palsy, but many
Yes, that
children
is
who have.
so.
Hello, sir.
I'm with you.
Okay, many children who has a lot of these contractures, and in some of these cases, I've even interacted with the referring pediatrician
Okay,
about the of administering the Botox injection to them so that it can also enhance my work and what I do.
yes.
But I've noticed that oftentimes they're always very, very reluctant. In fact, I've never seen anybody who was willing, to go ahead with the procedure before. So I want to ask that the Botox injection, is it only in theory or is it really practical? Do people do it? Because like I said, I've encountered such cases myself on one or two occasions, and relating with the doctors attending, it seems they are so reluctant, like it's not something that is frequently practiced, or maybe I just want to get your opinion about that, sir. Thank you.
Yeah, thank you, ma. And actually, you said something that is also happening. Is like, can I say, it's common in all the hospitals that we work.
Yes, I've
But
worked in like
yes, I come to realize that probably it is not the part of the routine practice in Nigeria.
okay.
There is something that you as the therapist may not influence, probably the medical and dental council or whatever, if they now see the reason why they should now start doing it. And it is not something that you just start doing it, you need to send people to learn how to do it.
Okay.
It may take some time. Probably when they now begin to send consultants or registrars to go and learn how to do Botox injection. There is Botox injection, there is phenol injection, there is what do you call it, selective doser isotomy, and all these guys for spasticity. The major problem is that if we really don't have the expertise, and some of these Botox, botulinum toxin is a very dangerous thing. Therefore, if actually you apply it wrongly, it can lead to what do you call it, severe consequences on the child. Therefore, I really felt that is the expertise that is needed. Somebody will never tell you that I really don't know how to do it, or I wasn't trained to do it.
Okay.
Yes, I think it is the training. Like, for example, like in the last presentation they had last week, we have somebody who trained in Ukraine, I know, who trained in Poland, and he did his master's. In his master's research, he did PNF, and he has to undergo 3 weeks of PNF training with certificate. Therefore, it is easy for you to tell somebody that I will do it today, I will do it tomorrow, if you are not really trained. But somebody who is trained will tell you, yes, let's do it, because he has been trained and he has been certified to do it. I really feel that I don't think there is any hospital in Nigeria that is doing Botox injection or phenol injection or selective doser isotomy. They only give injections, what do you call it? They only give drugs. I think that is it, but I really don't know. But I think it's the expertise that is missing.
Okay. Thank you so much, sir. Because it was in my own personal research in the first hospital I worked. I worked with the Navy in 2016,
Yes.
and it was
Yes.
during my own personal research I saw that Botox injection can really work for contractures. And like I said, I suggested it to the doctor then, but I noticed the reluctance was really much. They were not open
Yes.
to it. They just kept emphasizing physiotherapy and all of that. And at
Yeah,
that
they will
level,
never tell you.
okay.
No, that is when they talk to you and they show their weakness, then you now say, okay, they really don't know it. But the issue is that the trend has now changed, that we don't allow children to develop contractures. What happened is, even when they develop contractures, there is always a way out. We can do something. And then, but what we can do is probably outside our expertise. Then definitely the patients are really going to suffer.
Exactly. That's my
So
point exactly.
we keep
Thank you.
praying when they develop the expertise, then we can work together with them, because immediately they do Botox injection, the next thing is the patient will develop another weakness, then they'll have to come to physiotherapy again.
Oh, all right. No problem.
Okay,
Thank you
thank you
very
very
much.
much. Thank you,
for
man.
clarifying that. Thank you, sir.
Okay,
Thank you.
comments, contributions.
Thank you for the presentation, sir.
Okay, thank you, sir.
Yes, sir.
Hello, good afternoon.
Good afternoon, I'm with you, sir.
All right, and thank you for the presentation, Doctor.
Thank you, sir.
Really appreciate you.
Thank you,
Yeah, in the way of comment, contribution, I want
okay,
to
sir.
add to your voice that is actually the expertise that is missing in the area of that's the Botox injection practice. You are
Yes, sir.
right that to say that it's because they are not knowledgeable or they don't have the expertise in
Yes, sir.
training to apply the Botox injection. That is the actual truth behind the reluctance that our sister was facing in our practice, sorry. And I want to say that it is not only in the aspect of the Botox injection practice.
Okay, sir.
We also have it in when you refer an Palsy or clumpy palsy patient for surgery.
Yes, sir.
The expertise in also doing the reconstructive surgery is still lacking in Nigeria.
Yes, sir.
In my practice, using the Toronto
Grading.
score test,
Yes, sir.
the outcome measure, the Toronto score test,
Yes, sir.
to assess our patients, and we discover that maybe
Yeah, okay, cool. Office.
to
Hello.
hello.
Okay, I'm with you.
From the pediatrician, that is for us, that is the route of referral.
Yes.
You refer to the pediatrician will then refer to the ortho.
Yes, sir.
We always find out that they will eventually refer the patient back to us. I ask the mother to go and continue physiotherapy.
That
And
is it.
the truth is that the expertise is not actually there to do the reconstructive
The surgery. Yes.
surgery. And so
yes, sir.
it's not only in the Botox area, we have it also when we are having patients that are not having good prognosis that may need surgical intervention. You also see reluctancy in that aspect. They don't actually come up to. I've not seen any patients that we referred that surgery was conducted on the patients.
And then
On all my practice.
you listen to one of the participants here. She was asking whether that particular surgery, what will be the outcome. I said, no matter the outcome, the issue is, do we really do it here?
Do it, yeah. We don't. They don't do it.
We don't. Therefore, as it is, even when we have, that is why I always I prefer to use the word we having discussion with them, because when you refer,
yeah.
the patient will still come back.
Come back, yeah, that's true. You are right.
Yeah, the essence of having discussion is for them to understand. Okay, they also have limitation. Yes, the limitation is that we have done our best based on what we can do, but there is something happening within that it has to be rectified before physiotherapy can continue.
Yeah, that's true.
And it's good for them to know that, yes, we are not really just going. We really know our part.
What we are doing, yeah, that's true. Yes. So my question
thank God for everything.
Thank God. My question is the aspect of how do we, because that is the major challenge with our success in managing Palsy.
Yes.
And that is the winging of the scapula. How do we actually manage that? Is it possible to manage not have wing scapula? Because in my practice, I've come to understand that we might eventually have close to 90%. There are some that we say, okay, we can say more than above 90, because the mother will tell you there is no problem with the hand, that the hand, you can't even know that the baby had any problem with the hand, but that I should look at the back, that it seems there is a portion that is raised.
Coming out of the back, yes.
So that is the remaining in my practice, that is the only challenge. How do you go about that? Or
yes, actually, I try to see if we can get a particular treatment technique for winging of the scapula. But what I got mostly is that we should restrict scapular movement whenever the children are making general movement of the arm. The parents should also know it so that we don't increase the movement. As the child is improving, then the winging will be reducing. But actually, specific movement technique, one thing with the scapula is that it's attached to the rib cage. You cannot exercise it. Yes, it's like it is attached by the serratus anterior and all this, what do you call it? The muscles that attach it to the wall. The major problem is, I always advise restrict movement of the scapula. When the child becomes stronger, then the winging reduces. But when you move the scapula, because the scapula tends to move faster than the hand, it follows the movement. Therefore, you restrict movement and you move the hand, except I really don't have any special technique of physiotherapy that I know that is meant for winging of the scapula. And you cannot tape it. You can only restrict the movement, and you teach the parents to restrict the movement of the scapula as the child continues to do upper limb exercise. Gradually, the tone of the muscles controlling the scapula will return. But it's another thing that members of of this forum will also look at. Let's go and read about how do we stop winging of the scapula, apart from restricting the movement when the child is doing arm exercises, most especially shoulder exercises.
Okay.
Yes, sir. Exactly, sir. It's a challenge.
Actually,
Thank you very much.
Up to now, there is no specific technique that will prevent winging of the scapula.
Okay.
I know, yes, in Bobat, somehow, she has tried doing something, but still it has to do with just restriction. But I'll still read about it small in Bobat, more especially in adults are hemiplegia.
All right.
Probably we may relate that to seeing if you can add something to pediatrics.
All right. Thank
Yeah,
you.
thank you.
God bless.
Thank you, sir.
Thank you.
Adeyinka Adebayo.
Sorry, sir, can I come up?
Okay, come up,
Good evening,
sister.
sir.
Good evening, ma.
Deborah, can I speak up, sir?
Yes, please, please. We
Okay,
are
thank
sharing
you very
knowledge.
much, sir.
Thank you, ma.
Okay, sir. I want to contribute to what the last discussion about wing
Okay.
scapula.
Yes, winging of the scapula.
Yes, in my line of practice, sir, the success rate we've been able to get is because we engage the serratus anterior, the rhomboid, the teres minor, even in the line of management through weight bearing.
Okay.
Most of the time, if you engage, if you allow the infant, you know, when in the first 3 months, most of the time when we are treating, we concentrate on the biceps and the deltoid because
Yes.
we want to achieve that shoulder flexion. But
And
a
what
lot
we
of times,
usually see
when
obvious deformity, we did not look at we usually don't look at the back of the shoulder.
So we now the back of the shoulder. So when the child is achieving that shoulder flexion, a lot of time the scapula is just fixed. So the serratus, the rhomboid, they are wasting away. They are getting weaker and wasting away. So most times you now find out that the child that has wing scapula has a very fixed scapula. You're not talking about scapular mobilization, but at that time the muscles are already weak and wasting. So from the early stage, even as you are building, strengthening the deltoid and the biceps, you also encourage weight bearing. Weight bearing, I can point to one of your slides that you talked about. When you put the child in prone lying and you allow the child to lean on the elbow, and playing on the elbow, trying to lift up his head on the elbow. Every activity that involves bearing weight, either on the elbow or on the wrist, engages the muscles of the scapula. So you find out that each time you encourage this, there is a limit to how much winging you can have as the child is progressing. But the winging will be much when we leave out all these ones and we just concentrate on the biceps and the deltoid while we are treating. But if you engage them early enough, most of the time you have very little winging. And then the little winging now can now improve when the child is older with pushing against the wall, pushing against meeting ball, pushing against objects, every action that involves shoulder protraction and retraction. It can now help to reduce it. So that is one way we've been able to at least achieve reduction of wing scapula in Heb's palsy.
And do you know something we have forgotten? In the entire presentation, I think we only mentioned winging of scapula only once. You see, that is also another place where participants in this, what do you call it, in this forum should also look at, and then buying your idea and also practicing it. Because this is like more of a clinical, what do you call it, seminar we are doing. Therefore, whatever we learn here, we fertilize ideas, we now go and practice.
Yes, because
so
over time we notice that the parents are concerned about seeing the child move the hand. So everybody tend to forget the back. As long as the child can lift, can take it to the mouth, they are satisfied. And even physiotherapists, we too, we forget the back. But at the end of the day,
you know something, even literatures that talk, they only concentrate on the arm, the shoulder, even the scales concentrate. None of them talks about the winging of the scapula, with the exception of the physiotherapists that actually used to see this on the patient. Therefore, it's a good thing. I really thank the person that brought this up, and you that has contributed, and all the people that have listened. It is a food for thought for us. We should not concentrate on what we usually see in the hand. We should also go to the back of the shoulder and see whether the child has wings, scapula, and we should also try to manage it. Thank you very much. I really appreciate this contribution. Thank you very much.
Thank you, sir. Sir, why I raised my hand, sir? I looked at the slide you gave about older children. Sir, one of the major problems we have in clinic are the poorly managed EBS cases that they now bring back to you later. when the child is 10 years old, the child is 8 years old, the child is 12 years old, you have a 14-year-old with poorly managed herpes, and you see the shoulder already, the shoulder is contracted, the elbow, the biceps is contracted, there's limited range everywhere. And I'm beginning to look at that slide, sir. How can we achieve anything? My physiotherapist most of the time will say, man, there's nothing we can do. It's better we tell the parents. But I'm of the opinion that for as long as that child is to me less than 16 years, we may not be able to improve much, but we can reduce rate of improving deformity. I don't know if you are hearing me, sir. Hello, sir. Hello, sir.
I lost the conversation, please.
Okay.
My system was down a bit. I lost the conversation.
Okay. I was talking about the older children.
Yes.
One of our major problems in clinic is the older children, 8 years, 10 years, 14 years, 12 years, with poorly managed herpes that the parents now bring back to the clinic.
Yes.
And the general idea, you already have a contracted shoulder muscles, you already have a contracted biceps, already atrophied muscles. And the general idea, my physiotherapist always says, ma, there's nothing we can do. It's better to tell the mother there's nothing we can do. But I'm of the opinion, which I always tell them, that we can limit increasing deformity because this child is still growing. As long as it's still growing, you'll keep having increasing tightness, increasing contracture, increasing wasting. But even if we cannot improve, we can at least limit it by physiotherapy.
And
so that way, okay,
yes, I'm with you, ma. I'm with you.
Okay, and that way I encourage them to start physio. Now, when they start physiotherapy, basically my goal is we want to achieve as minimal as possible functional use.
Yes,
I encourage the parents that if the hand is in flexion, it is still better than the hand is in extension. An extended hand is practically a useless hand.
Yes,
because the functional position for the hand is flexion.
Slight flexion, yes.
So if we have a fixed flexion, what we can do is, let's see how much we can increase the range in extension, increase the range of shoulder flexion. That way, we are also limiting increasing deformity. Yes, and whatever we achieve. So I would like to know your opinion, sir, because this is where the major problem is.
You know, ma, the general opinion is like your opinion is the general opinion of most physiotherapists, the ones that really taught us, because physiotherapists will never say or never tell patients, go, I have discharged you, based on the fact that he sees the potential for developing deformity in that particular individual. That is why stroke patients used to remain with us for some time, despite the fact that this individual can walk, but he has seen the potential that a deformity is likely to set in somewhere. We still allow the individual to keep coming. Even if the frequency of what you call it treatment is going to reduce, but we want to keep monitoring so that that individual will not develop deformity. That is something with these children. When they refer them to us, no matter what, when they reach the clinic, no matter how worse the condition is, the physician will refer the patient to physiotherapy department. Then physiotherapy department is the only hope of this patient. And when we ask the patient to go home, where is he going? What you said is right. We can, even if we cannot achieve something, we cannot improve the patient substantially, but we can prevent deformity in the patient. We can also bring hope to the patient. With time, at times, what you see as something that is hopeless will become hopeful for you. If the patient remain compliant, most especially the caregivers keep coming, one day those hopeless cases you are seeing will end up becoming a story to tell people. Because as the child
Later,
is growing,
okay.
yes, as the child is growing, some things are changing in his body system.
Yes.
Some of the exercises we give is just because we used to say probably we are eager to see improvement. At times, 1, 2, 3 months. But at times, some of these things, if they are continued for up to 1 year and they keep coming, one day the parent will be telling you that at times you may even forget. The parent will say, this is the amount of improvement we have recorded.
That we
It's
have
not
seen.
actually,
Okay.
yes, it's not encouraging to tell for a physiotherapist to say, this is a hopeless care, let them go home. Where are they going? They should remain with us. We keep managing. As far as the patient remain faithful, then we should also remain committed to helping them.
Okay.
That is my take.
All right. Thank you, sir. I'm grateful. I really appreciate, sir.
Thank you for your contribution.
Thank you.
Thank you.
Thank you, sir.
Okay. Who is on the line?
Sorry, I didn't catch the bio.
Okay.
Can I?
You're welcome. You're
Okay.
welcome, man.
Good evening, sir, and good
Good
evening,
evening.
everybody. So my contribution was going to be about the last that was before the last person made a comment about scapular winging. So, but I think she
Okay.
kind of addressed a number of things I wanted to raise. But I also like to add that in my practice, I notice it's more with the older children that even sometimes those below one, but those who are below one who end up having the winging are those whose initial management was very poor. And a lot of times the adaptations, which a lot of times might be weakness from atrophy and all, can result in that. So for those who we begin to manage and then there's some bit of progress where they now begin, they're able to, they're of the age where they begin able to do do activities like play. So the throwing and catching activities you talked about, I found them to be very useful. And then, so, because, even in adults, much of activities are more of punch, like work on the serratus anterior.
Yes.
And then, like the other person mentioned, weight bearing. So I find also the 4-point kneeling, especially children who are older than 6 months and all, kneeling in 4 points, that weight bearing too also helps to engage the serratus anterior.
Wow.
So, but going forward, she also raised another important point about older children. For me, because I'm more of a musculoskeletal person, I see adult, but I see musculoskeletal pediatrics. So I find a number of older children coming after a long time, some below 10 and others in their early teens. But one thing I find to be the issue is a lot of times, even those who had early management, they did it for a short time and then left out of disappointment. So one of the things I do in my practice is we assess for the rehabilitation potential of the patient. So because you find out that sometimes people have more milder nerve injuries, but because the initial management wasn't well done, the disabilities and impairment and all is there where you have a lot of tiredness, a lot of limitation in range of motion, a lot of weakness, but not necessarily because of the potentials of the nerve. So one of the things that could be done is if one can establish a degree of nerve injury, if the nerve we actually recovered, but what you have is the consequences of improper management, most of those patients end up having very good functions, even though there'll be some bit of deficit. So first thing I like to do is try to do a proper assessment, determine rehabilitation potential, then educate the parents so they don't do a few months and then decide to leave, because at that point, we have to do whatever we're doing in form of sequence. So you don't go and try to just improve range without trying to balance with strengthening. So, but just to cap it up, I just wanted to add to that where I'm like, if because again, like you said, there isn't so much about this out there in the literature. So from our practice, we might be able to put these things, document them, could start from case studies and all, document them so others can practice and then see it work. But I found them to work very well in my own practice. So initial assessment, establish rehabilitation potential, focus more on functional rehabilitation, and then what do you call it, educate the patients and the caregivers, so they don't abandon the treatment, and then it makes it look like, oh, there's nothing physio can do. Thank you, sir.
Thank you very much, ma. Actually, I really appreciate your comment. Also, it's something very wonderful and clinically very, very relevant, because something that is very, very important is, please, even in our hospital, there is what you call so management protocol. Like for us here in Kano, we can say AKTH management protocol for Epilepsy palsy. Therefore, something that has worked for us, this is what we do. This is what really helps us. This is what makes our patients recover. Therefore, we should have it. This is the management protocol for Epilepsy palsy. Therefore, whenever somebody wants to manage Epilepsy palsy, we have done this. This is our protocol. Then we follow it. Therefore, and it will definitely always work for us. And then what we are really saying here is, for those that are really on this, that are with us, that she said there is a management protocol they followed in their place, and they have made it routine that whichever child comes with winging of the scapula, they followed, and it actually helps. Another factor is that we should do thorough assessment of the rehabilitation potential of the child, and we encourage the patient, because if the child has good rehabilitation prospects, the child is going to improve, and the parents refuse to come in after some few months, they are not really helping the child. Another thing I would add is that part of rehabilitation protocol for children with Epilepsy palsy, they should know that the rehabilitation will last minimum 2 years. But actually, based on the literature, I have seen rehabilitation protocols for up to 4 years, meaning that yes. Okay, please, probably, are we together, please? Hello?
Yes, sir. We are with
Yes,
you,
sir,
sir.
we are with you.
Yes.
Sir, we are with you.
Yes, actually, we used to
And
have this, can we say, wrong notion about coming to physiotherapy departments. I was opportunity to work with Professor Adorenki Akimpelu when I was doing my PG program in Ibadan. Actually, she has a private clinic that whenever a child comes with a particular, what do you call it, neurological disorder that requires long-term management, she would advise them to come to UCH. She would even bring them to UCH herself. The reason being that probably the amount of money they charge in the private hospital may not allow the child to keep coming for 2 or 3 years. Therefore, she encouraged them come to UCH. Probably the charges are less, so that we continue managing you. Therefore, the essence is for them, we facilitate their coming. We shouldn't give them false hope that within 1 or 2, or that aspect of education that you said, Ma, is very, very vital. Educate them about the condition, the recovery prospect of the child, the length of time they are going to continue having management with us as physiotherapists, and then what we can do, what they can also offer to help the child. And then specifically, what are the specific limitations of the child? And then there will be the one that will be judging. As the child is making improvement, they will be saying, yes, when you tell us about this, we can see improvement. It's like a more of family-centered approach that we are giving. The family is being taken, into the picture of the whole rehabilitation process. Thank you very much. We really appreciate you for your comments.
Thank you, sir.
Thank you, ma'am. Okay, in the absence of further comments, I want to thank
excuse
everyone. It has been a very good. Okay,
I
you want to
I
say
have a
something?
question.
Okay, Edna.
Yes, sir. Good
Okay,
afternoon, sir. Good evening, sir.
Good afternoon. Good evening, Edna.
Sir, my question is about this electrical stimulation for Erb's palsy.
Yes.
I know that there's no consensus on its
Yes,
use.
up till now.
Yes, sir. But sir, I
Yes.
don't know if you'll be willing to share your own treatment protocol in AKTH. And the second part of the question is it better to stimulate the older patients or younger patients? And another part of the question again is I don't know if we can have a consensus about when electrical stimulation will be used. I've seen several cases where after stimulating, there's serious hypertrophy of the muscle fiber because some people will start stimulating before the baby is even a month old. So, sir, I hope my questions are clear.
Yes. Actually, let's talk about this electrical stimulation first. Actually, in the protocol I use today, I don't think from the beginning to the end of the protocol there is mention of anything electrical stimulation. It's actually not part of what the pediatric group of the what do you call it? Chartered physiotherapists have recommended. But nevertheless, we are researchers. Therefore, there are researches that mentioned, and then I told you that there are systematic reviews and meta-analysis on the influence of what do you call it, electrical stimulation on the recovery of children with brachial plexus injury. Nevertheless, no matter what obtains in the clinical practice, this is research, and what research says is that it's useful. But how you apply it is what matters. Actually, the literature is more keen on positioning, on range of motion exercises, on stimulating active movement in the child. The literature actually talk less on electrical stimulation. What we usually do in the clinic, because we really don't have the time, there is the first thing I learned when I was doing my PG is that my particular range of motion exercise. If I do 10 range of motion exercise for supination, I was told that it's useless. I should do at least 50. I should do 10, the child rests, at another 10, the child rests, another 10, meaning that in the whole arm, I can spend like an hour in the arm of the patient trying to do passive mobilization of the hand. Therefore, what is there is we as physiotherapists, what we do is generally, and for many, is like when we have this electrical gadget, it's like they are, because is it MRTB or NUC, because when they want to come for accreditation, they want to see gadgets. We felt that these gadgets actually, no, they are adjuncts, but exercise is main. Therefore, we should concentrate more on both assisted active, free active, stimulated exercises in these guys rather than what do you call it, the electrical stimulation. We can give electrical stimulation, but at times you can give movement. It's not as therapeutic as 1 hour passive. If you do 100 passive movement, it's never going to be as therapeutic as one active movement the child does. Therefore, what is happening is we should encourage the child as much as we could to make active movement, even if it is in gravity counterbalance position, rather than stimulating or giving passive movement. Therefore, all our attention, all our expertise should go towards trying to see even how do we stimulate active movement in these children. Passive movements are not actually out of it now. That is number one. Number two, for a protocol, actually in AKTH, we don't have a single protocol that is made for Erb's palsy, a written one. It depends on the experience of the therapist handling the patient. But what you said is very important. We shouldn't rely so much on electrical stimulation. Electrical stimulation actually works more. I have seen so many literatures works more on patients that have active, what do you call it, that have active activity level. It helps, what do you call it, individuals that have active activity level, those that can respond to command, older children. But for younger children, yes, you can do it, but actually it shouldn't take the center stage. If you like, I don't know, based on your experience, if you stimulate the muscle group of somebody who has, is it CP or stroke or anything that are weak. At times when you touch the muscle, it is as if there is stone inside the muscles. The muscle will now become, what do you call it? It's like the tone is increasing. We should do electrical stimulation sparingly. We should encourage active movement, active exercises. They are more useful to the patient. I think I was able to answer 2 of your questions. I don't know,
Oh, yes,
Edna.
sir. Thank you so much. I also don't believe in electrical stimulation for
No,
this
yes,
condition.
one can, is in a way, because the literature did not say don't give. Is that not so?
Yes, sir.
But it shouldn't take the center stage, because I have a new electrical stimulator every day. And at times, even if it is an elderly person, the little tone you used to see that encourages you, at times it's just like becoming hypertonic again. We shouldn't overuse the electrical stimulation.
Yes, sir. Thank you so much, sir.
Yes, and another thing, I don't know whether you observe this. Some of us, instead of using neuromuscular electrical stimulator for children, we end up using TENS. TENS is
Yes,
not
sir.
electrical stimulation.
Mm.
TENS, because we see stimulation of the muscles, actually is not meant to stimulate muscle. We should look for EMS, not TENS. That is another thing I want to say about this. Thank you very much.
Thank you, sir.
Maria Musa.
Sir,
So,
sir, please, for those patients that are developing claw hand, since we said that we know are aware that the surgery is very rare in our area, is there
Wallahi, it's rare.
is there any physiotherapy intervention that we can help all these patients that are coming with the claw hand?
Yes.
And
Immediately you start claw hand,
mm,
you understand? You use an orthotic
yes, sir.
device. You know, claw,
Okay.
yes, use an orthotic device. I managed a patient with stroke that came from Egypt. Right from the day they were admitted in Egypt, they gave him cock-up splint for the upper limb, a very strong one. Up to the time when the patient come to us for management, he has never developed that upper limb flexion contraction. Despite the fact that the hand is still weak, but that flexion contraction is not developed. Therefore, one thing is, immediately you realize that this guy is going into what do you call it, having claw hand, fix him with cock-up splint. Yes. Therefore, despite the fact that probably your treatment procedure or there is a late recovery, but the recovery will not leave. We will not meet the hand of the patient in a deformed position.
Okay.
We are free
So,
to
sir,
use
about
orthotic
the
devices, prevention of contracture and deformity. And in such cases, in your case, cock-up splint can do it.
Okay. So thank you, sir. And sir, still about the issue of this stimulation. What about those patients that are coming with early stage flaccid? Is it advisable to stimulate not only in ELPS? You see patients, some patients with spinal bifida coming with a paralysis of both lower limb post surgery. They are coming in flaccid state. So in such situation, can we stimulate?
Therefore, one thing is, I take stimulation as adjunct to exercise when the patients now begin to show, even if it is flicker of movement, I think stimulation will help. But is there any literature that says flaccid, a patient with flaccidity, stimulation is going to work for him? Where you have movement, no matter how little, you can augment that with stimulation and with a lot of exercises. Cool?
Yes.
That particular passive movement, that particular taking a lot of time encouraging the individual to do some active movement is required of us. But to go and read in the whole of literatures for physiotherapy that involves what you call it, flaccidity, you will never see electrical stimulation. Electrical stimulation is given where you have some little movement, then you now augment the movement with exercises.
Okay. Oh, thank you, sir.
Thank you. Okay. Let me take last comments before I go for prayers. Do we still have? I can see one hand up again. Hafiz Karaji. Okay. In the absence, we really have a fruitful discussion today, and I really salute your contributions, and it shows that we really flow together. And we hope that our next presentation will stimulate active and what do you call it, knowledge synthesis. And I really appreciate this particular presentation. Thank you for all the participants for listening and your contributions. We'll call it a day till we meet another time. Thank you.
Thank you, sir. You're welcome.
Oh, thank you, sir.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you, everyone.